from our speakers, and sir is trying to really look at things which are basically, ECT is a major stigmatizing modality of treatment, but I think first of all we ourselves should be very confident in looking at ECT as one of the best options. I think Dr. Keshwara sir is here, Sandeep is there, and we have Chitran and Reddy sir, who would definitely give us the best possible inputs. Hope the PGs will join by that time, many more PGs. I request the guest of honor, Dr. KP Joshi, the Vice Principal of the Institute, to address the gathering.
Thank you, sir. Respected Chief Guest of the function, Dr. K. Chandrasekhar sir, Mr. Vice President of this society, Dr. V. George Reddy, all other members of the EC, Organizing Chairman, Dr. Ashok Reddy sir, and our Organizing Secretary, Dr. Prateek. All the delegates, speakers, and postgraduate students. Good morning, one and all. It's really a great pleasure for me to stand before you on behalf of the institution to welcome each and everyone for this, wonderful opportunity, as you can call it, academic feast organized by none other than our Dr. Ashok Reddy sir. I really appreciate his efforts in organizing such programs, because many of may be coming first time, but I think so myself is coming third or fourth time in this auditorium on behalf of the institution, starting from that last conference, then again post-conference, one CME, and many other programs. As far as concerned, this organizations of this such kind of programs, our management always encourages, our administration always encourages, especially as you heard, our dynamic managing director, Dr. K.J. Reddy says, we always put our efforts to encourage such activities in our campus. We always see that such habits among the undergraduate or postgraduate should be inculcated to understand the new upcomings or the new challenges or the new things which are happening in the field of medical science. It depends on individual branch. And I really again congratulate Dr. Ashok Reddy sir for selecting such theme, because if you read such articles in medical education, usually there is one thing comes, there is a huge gap between the knowledge and skill. That is called gap, knowledge, attitude and practice between the knowledge the people may be having, same with the undergraduate level, same with the postgraduate level. Even after postgraduation also, there is some lag or there is some gap between the sound knowledge and the practice. And the research says that the people are having sound knowledge, but still there is a gap which they are not able to put it in the practice with confidence or with that attitude which is needed actually to put it in the practice. So such programs are, I feel, it is like a great opportunity to everyone, even those who are like, I am very happy to see the names of the speakers. I really, I am thankful that they have all come all the way to address this program, and they will be taking the sessions. So it is a great opportunity for youngsters. Even it is refreshing for all the faculty also to discuss the new things or even their experiences in the field of particular in the field of psychiatry regarding their biological treatment. So again, once again, sir, thank you so much for, I really appreciate the efforts of Dr. Ashok Reddy sir for organizing such program. And thank you for the society for choosing our college. It's really honor for us. So thank you, the chairman sir and vice chairman, for giving us the opportunity to organize such program. Thank you very much for giving this opportunity. Thank you.
Thank you. I think at this outset, we should really again thank Dr. Ashok Reddy sir for selecting a perfect chief guest for today, Dr. Chandrasekhar sir, because many times I'm sure all of us, when we look at the tough times of treatment and where both competence and wisdom has to prevail, I think there we knock at Dr. Chandrasekhar sir's consultation room. And definitely particularly in this topic, what we are going to deal with. It could be ECT, it could be RTMS, all this matter. I think sir has vast experience, and I'm sure his address also will be like a short presentation for us, and we can really learn great from him. Thank you, Dr. Ashok Reddy sir. Thank you, Dr. Chandrasekhar sir, for being with us. We will inaugurate the training program by watering the Tulsi plant by the chief guest and all the dignitaries. I request today's chief guest, Dr. K. Chandrasekhar sir, to release the Telangana Journal of Psychiatry. I request Dr. Sai Krishna, our editor, to give his message about this journal today.
Good morning. I want to congratulate the entire team of SVS Mahboob Nagar for making beautiful arrangements for this PG training program. And I want to thank Ashok Reddy sir personally. I want to thank founder editor Dr. Fani Prashant sir for being with us today. Today we are releasing volume 7 issue 2. It was online from January, but the hard copy we are planning to release only during conference. That's the reason why we had postponed to March. And I request all the postgraduates who are here to regularly participate in academic activities, and they can take help of their faculty and start writing research articles. Okay? Thank you.
Thank you, Sai. I request our chief guest, Dr. K. Chandrasekhar sir, to give his message.
Dr. George Reddy, presiding officer of today's function and Vice President and President-elect of IPS Telangana State Branch, Dr. K.J. Reddy Garu, Managing Director, SVS Medical College, Dr. Ashok Reddy, Organizing Chairman of this conference, Dr. K.P. Joshi, Vice Principal, SVS Medical College, Dr. Pavan, Dr. Narayan Rao, Dr. Sai Krishna, Dr. Vijayaraj Pratik, all my colleagues, both seniors and juniors. Today's CMA program, I would say, is one milestone in any CMA programs, because what the organizers of this program has envisioned is how to transfer the skills which are necessary in today's practice of psychiatry. Though we read a lot of literature about these treatment aspects, unfortunately their practical utility is not yet being realized by a majority of the psychiatrists, and also their application in day-to-day practice has to be further strengthened. But how do you strengthen their application is by gaining more and more knowledge about those treatment modalities. For the student of psychiatry today, it is very imperative that they have a very sound knowledge of neuroanatomy, neurophysiology, and neuroimaging, almost, I would say, to the level of a neurophysician or a neurosurgeon, if not more, because almost every major psychiatric disorder today which we treat, the origins have been traced to some disturbance in the neurocircuitry. Unless your foundation is very strong in the anatomical aspects of these disorders, the anatomical origins of these disorders probably will not be doing much justice in the long run. So in today's psychiatric practice, all the youngsters, especially the young postgraduate students, should spend at least 6 months of their initial training absolutely in learning as much as possible of neuroanatomy and neurophysiology. Then only they can shape themselves into better psychiatrists. Because the emphasis which you had on these two aspects in your undergraduation is not really adequate. That is one issue. And another thing, when we are applying these latest treatment modalities like RTMS or TDCS, or in fact even to some extent the ACT modalities of treatment, your diagnostic accuracy depends upon the localization of the areas which you are targeting in stimulation. So that again shows how important it is for us to have an adequate knowledge in these particular aspects. All of us know the mind and brain cannot be separated from one another. The mind-matter dichotomy has been challenged, and the best evidence of this comes from patients whose brains are affected because of injury or disease. Brain injury may change personalities, brain injury may cause disorders, and also we know how even drugs modify the behavior. Basically, it shows that the substrate for mind is nothing but the brain. Because once the brain ceases to exist, I don't think there is any further thing called mind. So in a practical, when you are looking at the clinical psychiatric practice terms, for all of us, it is, we believe that there is no dichotomy there, the behavior which I observe is a byproduct of the brain. And this particular aspect has crept into various biological treatments. May it be the electrostimulatory techniques, or neuromodulatory techniques, or even your pharmacological techniques. All these things basically modify the brain in some way or other. So we have to strengthen our knowledge as far as possible in this aspect. So today's CME program is all about how the various treatment modalities are helpful in psychiatric disorders and certain degree of precision nowadays. See, for several years, for several decades, you ask any other specialist, they will say, what is there? All your treatments are vague. Most of the opinion, majority of the opinion of the colleague physicians and surgeons is, yours is all a mumbo jumbo sort of a treatment. You just see the behavior and prescribe something just like that, and the patient responds or may not respond. This is to be the impression of the therapeutic measures in psychiatry. I don't think that opinion no longer exists, or we have to really give any credence to that sort of a opinion. Now psychiatric treatments have become more precise. In fact, most of the molecules which we tend to use are more specific, targeting a particular receptor groups or altering certain neurocircuitry disturbances. So it has become more precise. Our treatment modalities have become more precise. Only thing is probably the diagnostic precision is yet to come. And once that is, which I foresee in the next few decades, which is going to occur, once the diagnostic precision also occurs, I think psychiatry is like any other medical specialty, which precision in diagnosis, precision in treatments, and neuromodulatory techniques is one direction in precision of the treatment procedures. The deep stimulation of certain structures of the brain will definitely improve, especially in conditions like obsessive compulsive disorder, refractory hallucinations, and severe depressions. This has been more or less established, and I am sure in the lectures that follow, the speakers are going to really throw light on these aspects. And being a CME inauguration, I don't want to take much time. Thank you very much for giving me this opportunity to share my thoughts with all of you. Thank you once again.
Thank you, sir. I think a lot of things you have covered, sir. I think definitely it is going to open a lot of new ideas for the youngsters. At this outset, I would really thank our General Secretary, Pawan, who has been doing a lot of activities and keeping us updated. And to inform the August audience, I think our election notification has been released on time, on 1st of March. Those who are interested, please try to put your nominations. And we should thank Dr. Sai Krishna for bringing out the journal on time. And our treasurer, Dr. Narayan Rao, I think doing a wonderful job in helping Thirumal's family. And all following the footsteps of their dynamic previous members, Dr. Minhas, Dr. Vishal, Dr. Srilakshmi, Dr. Fanikant. And definitely we should really appreciate Dr. Jagannath sir and Dr. Minhas sir contributions for the last year. Because of them, I think Telangana could stand to get the second best state from the IPS. With this few words, I think I will request our chief guest to present the mementos, presentation of mementos.
Dr. the Chief Guest to present the memento to the presiding. I request Dr. Chandrasekhar Garu to present the memento to Dr. Kambampati Narayan Rao Garu. I request Dr. Chandrasekhar Garu to present memento to Sai Krishna Puli sir. I request Dr. Chandrasekhar sir to present memento to Dr. Vijay Raj Pratik sir. I request Dr. Chandrasekhar sir to present the memento to our Rufus sir. Thank you, sir, for coming all the way from Vizag.
I think hope we have covered everything in the inaugural. Yeah. So I request Dr. Vijay Raj Pratik Reddy, the assistant professor here, to present the vote of thanks.
Good morning, all. I think I'm audible. Yeah. It's a great privilege and honor to propose vote of thanks for this 7th annual PG training program of IPS Telangana State Branch. I, Dr. Vijay Raj Pratik, like to thank all the organizing committee members and IPS Telangana State Executive Council members for giving this opportunity. I like to thank our Managing Director, Dr. K.J. Reddy sir, for giving his welcome message. I would like to thank our management committee, Dr. K. Krishna Reddy Garu, Sri K. Ram Reddy Garu, Sri K. Venkat Reddy Garu, Sri Vijay Raghavan sir, Kanagarajan sir, and Joshi sir and Sushilamma madam for giving us the opportunity to conduct here and looking after the hospitality and structuring the program. I also like to thank Indian Psychiatry Society Telangana State Branch, who gave permission for conducting this annual program. I sincerely like to thank President Dr. Ram Subbareddy sir, Vice President Dr. V. George Reddy sir, Honorable General Secretary Dr. Pawan Kulkarni sir, Honorable Treasurer Dr. Kambampati Narayan Rao sir, and Honorable Editor Dr. Sai Krishna Puli sir, and also the past President Dr. Jagannath sir and past Secretary Minaj sir for giving us this opportunity. Also thank all the Executive Council members for gracing this occasion. I sincerely like to thank our chief guest Dr. K. Chandrasekhar sir, despite his busy schedule agreeing to be chief guest of this occasion immediately within short span of time. I would also like to thank our organizing chairman, my mentor Dr. K. Ashok Reddy sir for planning this program way ahead, almost 3 months ahead, and then selecting the topic of biological treatments to develop the skills in postgraduates. I also like to thank all the speakers, Dr. Keshwara sir, Dr. Chitranjan Andrade sir, Dr. Sandeep sir for taking their time and coming over here to deliver their demonstration over biological treatments for learning experience. I also like to thank chairpersons Dr. Minaj sir, Dr. Sai Krishna sir, Dr. Fani Prasad sir for coming over here and gracing the occasion. I would also like to thank our Department of Psychiatry, especially our Senior Resident Dr. Akila for looking after the scientific program and the inaugural program and the registrations of postgraduates. I would also like to thank my postgraduates for helping with all the organizing stuff. And also I would like to thank all the postgraduates who has registered for this program for a great learning experience. And also I would like to thank, as there is a quiz, our quiz master Dr. Sanjay sir and associate quiz master Dr. Om Prakash sir for coming over here to conduct the PG quiz at state level. I also like to thank Dr. Rufus sir for coming all over from Vizag to grace this occasion. And also I like to thank Mr. Anil Martin and his technical team for providing us the technical support. I also like to thank Crescent Pharmaceuticals for doing the program on this occasion, for providing all the support we needed. And last but not least, I would like to thank all the EC members and IPS Telangana State Branch for giving me this opportunity. I apologize if I forgot anyone's names. Sorry if I missed anyone's names. Thank you one and all. Long live Telangana IPS Society.
Thank you. I think all the postgraduates should, it's a challenge, I'm telling you. No one will sleep today. That is the way the programs are designed. So please make the best use who are going to be here. Trust me, these topics I'm telling you, even still I too have to learn from today. Sandeep, I'm going to learn a lot. And you're lucky that at your postgraduate phase you're going to know into so many things. And the legal aspects of ECT still, today also I still, I have to learn a lot about all these things. And we have Dr. Keshwara sir, Chittaranjan Andade sir. And again I tell you, take this opportunity because the IPS TSB every year conducts this kind of programs, and our target is to enhance learning abilities in the postgraduates. Thank you one and all. I think we'll stand up for the national anthem.
Thank you, everyone. We come to the end of inaugural program now and start with the academic program.
We'll be having the first session immediately. We'll be having the tea break after the first session, so please wait in the hall. And all the programs, we have deliberately not made it online this time, nor even hybrid. We wanted the PGs to come physically, attend and learn and pay total attention. That's the reason we made it only in-person program. And we are going to record all these things and it will be streamed. It will be available on YouTube after a few days. All other PGs, you could not come here, can just view
on through YouTube in the future. Thank you.
I request all the PGs to please come forward in the first benches.
Just on Sunday, we'll take a break of a short 5 minutes for arrangements and we'll proceed with the sessions.
We will be taking a short break of 5 minutes for the arrangements, and following that we'll go ahead with the ceremony, with the program. ఇందులో నెట్ ఉందా? ఇందులో నా మెయిల్ ఓపెన్ చేయొచ్చా? అవునా? త్రీ ప్రెజెంటేషన్స్ కాపీ చేశారు సార్. సివీస్ ఏం కాపీ చేయలేదు. మెయిల్ ఓపెన్ చేయాలా? మన ఇంటర్నెట్లో ఓపెన్ చేయాలా?
ఇక్కడ ఉంది ఇచ్చారు.
మ్యామ్ ఇందులో డౌన్లోడ్ చేశాను సిరీస్ అక్కడ ఓపెన్ అవుతాయి వెనదర్ సార్ హెచ్ఓడి సార్ So starting with the PG training program, the first session for today is update on ECT practical demo and legal issues. This session will be chairing by Dr. M. Fani Prashant sir. Dr. M. Fani Prashant sir completed his MD from PGI Chandigarh. He worked as senior resident at NIMHANS, started private practice in Care Hospital, now director and consultant psychiatrist at Chetna Hospital, first editor of Telangana Journal of Psychiatry. I request our chairperson, Dr. M. Fani Prashant sir, to introduce our speaker, Dr. D. Keshav Rao sir. Yes sir, yes sir.
Good morning, everyone. It's a very pleasant day. Okay. I don't think I need to introduce Dr. Keshav. He's my colleague at Chetna Hospital. We all came together and started the Chetna Hospital as directors. Okay. He did his MBBS from Warangal Medical College. Okay. And then he actually went to UK, did his PG in IMH, and then went to UK, did his MRC Psych. He stayed there for a long time, so we have a great experience from different cultures, like how the practice is in India and how practice in UK we can know from him. Anytime we have any doubts in Mental Health Act or any way how things are done in UK, we generally go to him only. And he has special interest in child psychiatry, ADHD, autism and CBT. He is a very special, he is very well trained in the cognitive behavior therapy and other modalities of psychotherapy. So if you are looking to learn cognitive model of therapies, then Dr. Keshwara is the one who is the best. Okay, and he's very well known speaker to all of us. Okay, so I welcome you, sir. Okay, yeah, so.
Thank you, Fani.
Today's topic is a very interesting topic. That's okay. Today's topic is a very important and a practical aspect for all the PGs. Okay. I hope all of you have seen at least one ECT till now. Hopefully. Yeah. Okay. So ECT is one of the oldest and the well recognized and very effective treatments, somatic treatments in psychiatry. Okay, so if we look at the history of electroconvulsive therapy, it started off somewhere in 16th century when alchemists from recognized that by inducing seizures, they can treat lunacy. Okay, this was done with the camphor and oil in the initial phase, where camphor was used to induce seizures. Later in 1960s and 50s and 60s, okay, most of the people who were having mental illnesses at that point of time was called as lunacy, were treated with camphor on oil and some chemical called metrazole. Okay. In 1950s and 60s, this was the main modality of treatment. Okay. In 1938, Serletti and Benny, these are the two scientists who mastered the technique of giving electric current to the head to produce convulsion. That was when it was called as electroconvulsive therapy. That was one started in 1938, and 1950s and 60s saw ECT as one of the main modalities, because at that point of time, if you can remember, chlorpromazine was being introduced into the market. Okay, I don't know whether you'll remember the names of the scientists or not, but this is when pharmacology, psychopharmacology was started to go into the phase. So at that point of time, the main treatments which are available were psychosurgery, insulin coma, were severely ill patients. That was when this was seen as a miraculous treatment. Okay, with ECT shocks being given alternate day or daily, people used to be cured of mental illness. Okay, so there was a huge uproar. But slowly after 1980s and 90s, when the psychopharmacology started to pick up, and then you had new generation of antipsychotics coming in the late 1990s, and slowly the ECT saw a decline in the Western world. India, we still practice a lot of ECT from both private as well as in the government setup. We see a lot of patients getting ECTs, but if you see in the UK practice, as Dr. Keshara will tell us with his experience in UK, and even in the US, ECT is considered as one of the special treatments, not as a regular treatment in psychiatry. The most common indications we actually see about ECT is mostly for major depression, severe depression without psychotic symptoms, suicidal thoughts, or a patient who is not eating well, who is into a catatonic phase. Okay. The other indications are, as you know, it is schizophrenia, acute mania we give. And where safety is a priority, like let us say a person who has multiple medical morbidity and he is having a drug-drug interaction and he is not able to tolerate other medications, ECT might still be considered as a precaution. And safety is very high that you can give it in very elderly also. We have given ECT to patients who are in a 90-year-old also. And then patients who have pregnancy, it is very safe option in such condition. Where you need rapid recovery, let us say in puerperium, when the child, after childbearing, the very critical time for bonding between the mother and the child is very important. You need a rapid recovery there of any depression or psychosis, so postpartum psychosis, postpartum depression. ECT is most a first-line treatment in such conditions. And we should not forget that ECT is also important where there is a past good response to ECT. We should actually consider ECT as one of the first line. And where medication treatments have failed, let us say in treatment-resistant depression, treatment-resistant bipolar disorder, we can use ECT as the thing. And if patient prefers ECT over medication also, sometimes patients do come and ask us, sir, shock treatment kyun nahi dete hain? Okay? So you should also, it is most of a stigma from psychiatrists also to offer the treatment in the first line when you feel even if it is helpful. Okay, so these are the indications. There is no exact mechanism we know as how the ECT works, but there are theories which are there about how anticonvulsant effect of ECTs might help in membrane stabilization, and that is how actually it works. Or there might be some changes in the neuronal growth, like hippocampal growth can actually, stimulation in the hippocampal area can actually cause relief in depression and hormonal changes. There are definite areas where ECT is not likely to work, where severe anxiety, OCD, resistant OCD, these areas it has been proven without doubt that ECT is not a treatment of choice and it should not be offered at all. Okay, so with this short introduction about ECT, I would like Dr. Keshara to tell us as to how do we go about ECT. Let us say a patient is referred to ECT, how do we go about it in a practical manner, how do we give ECT, and if there are any legal aspects, how do we deal with it. Thank you, sir. Welcome.
Thank you, Dr. Fani Prashant, for your introduction and the brief note. Yeah. Good morning, everyone. At the outset, I thank the organizing committee for giving me this opportunity. Am I audible? And I also appreciate that Dr. Ashok Reddy has taken up this important topic, because as less and less PGs are getting exposed to ECT nowadays as compared to our days, right? And as a result, that these when they go out as practitioners, they may lose it as a treatment modality because they have never used it. They are uncomfortable even to recommend. So this is what is happening now in UK. Now, in 2000, I have gone to UK. At that time, the ECT suits used to have about 4 patients a day. But now most of the centers have closed down because the referrals have come down. They are losing a treatment modality. Now, I will tell you a real story, an incident. Even if you don't remember what I talk, at least you will remember the story. This is about the importance of ECT. In 1997, the Royal College conducted a regional conference in Hyderabad. And at that time, Professor Kendall, you heard about Kendall? He is the author of Companion to Psychiatry textbook. He was a long-time editor of that book and also long-time editor of British Journal of Psychiatry. He died just 2 years ago at the age of 96 or something. He was very active till his last day. So we were in a small room like this, and that was some session. And one doctor who did his psychiatry from UK was in the audience. He's from Kakinada, I don't remember his name. And this doctor, Kendall, was chairing that session. This doctor asked why the ECT is used for everything in India. He wanted to get an adverse remark, something supporting him. And Dr. Kendall said, it is not the question why it is used in excess. It is the question why in UK we are not using it as often as we should be using. With that fellow became silent. So ECT is accepted as a standard treatment by most psychiatrists in the world, except for those who have a different view of bent of mind. So take ECT as a positive treatment, not led by the psychology lobby or the general public lobby. Okay. So now we go to this preparation is mainly for postgraduates. I concentrated on basics, not on theoretical aspects like indications or other things. It is mainly on the technique of this thing, but we will go into some physiology also because it is important to understand the science behind it. Okay. Where is the slide? This one? This one? Next. Right. So first let us try to define ECT. So ECT is a type of physical treatment to treat psychiatric disorders by producing generalized seizures of certain duration by passing small dose of electricity through the cerebral hemisphere by placing electrodes on 2 sites over scalp. So electricity, a certain defined amount of electricity, and that stimulates the brain, and there will be a generalized tonic-clonic seizure. So that is the first step we are doing, right? And how it works, we don't know really. Okay. So there are types of ECT. One is direct ECT. Direct ECT, anyone knows what is direct ECT? Without anesthesia. And when I joined post-graduation in IMH, we used to have the direct ECT. There was no anesthesia. And also the amount of electricity was not predefined like that. We used to press the button till the person starts fitting, then we will release it. So you used to pass lot more current than required. Right? Now that is prohibited by MHCA 2017. So we cannot give direct ECTs anymore. And then we have modified ECT, which is the standard ECT nowadays we are giving. This is done under general anesthesia. This is the most commonly used practice in India. Then we have modified ECT, with EEG monitoring facility. So most advanced centers have this facility, but most of the clinics, nursing homes probably don't have this EEG monitoring facility. And now there are other types of also we can divide into unilateral treatment and bilateral treatment. Bilateral treatment, as I said, you put the electrodes like this, both sides of the scalp. But in unilateral, you put only one side, one here and one there, so only one side of the brain you use. So the electricity passes from this electrode to that electrode, and the brain gets stimulated. So you have to pass much more current in this, but this will have, because you choose the right one, so the cognitive impairment, memory disturbances will be much less. But bilateral ECT is easier to administer and is more effective. So most of our ECTs, almost 99% of our ECTs are bilateral ECTs only. So our focus will be on bilateral ECT. Okay. So this is the slide showing, okay. So where do you put the electrode? In a bilateral ECT, you draw a line from the canthus of the eye to the tragus of the ear, and about 4 centimeters above, you put the electrode. And similarly, on the other side also, you do the same thing. So that is the point for the bilateral ECTs. For unilateral ECTs, you can see the points on both are on the same side. Okay. So on the non-dominant hemisphere, on the right side, you do it. So it is also the same slide, same photograph in a different angle. Okay. Front. Huh? Yeah. Now this is the machine we have in front of us. So basically this machine, nowadays the ECT machines are very simple. You have these are fairly simple machines. You switch on the power and you will have a dosage dial. You don't have a dial here, but you have up and down. 2, 3, 4, 5, 6. You have 1, 2, 3, 4, 5, 6, 7, 8, 9. So 1 is 30 millicoulombs and 9 is 540. So like that. So you choose the amount of electricity in coulombs, and then you have a treatment button of this. You put the electrode, press the treatment button, and the electricity passes. The defined amount of electricity passes, and there is the generalized seizure. Right. And the electricity passes over 0.5 to 2 milliseconds. So you will hold it much longer because, 0.5 to 2 seconds, not milliseconds. 0.5 to 2 seconds it passes, but you can hold it longer because once the amount of electricity is delivered, no more electricity goes. So you will just keep it pressed for sufficiently long time. And then you can choose the electricity something between anywhere from 30 to 600. So from that 1, 2, 3, 4 numbers they have given, each one has got a different. Suppose 1 is some 60, 2 is 90, like that you choose. So then how do you observe the fitting? How do you observe the seizure? So one is the most commonly practiced method here is, so the psychiatrist gives the electricity stimulus, and a nurse or another trainee or somebody observes the seizure time using a stop clock, right? So they will see from when that seizure starts until the last point of the shaking, right? So this is not really a reliable method because you are giving anesthesia, you are giving muscle relaxant, and when you give the muscle relaxant, the muscle contractions are not strong. So There is another method to make sure, that is the BP cuff method. BP cuff method is you put a cuff around the arm, one arm, and then you raise the BP, this thing, above systolic, 10 millimeters above systolic. And then this you have to do before the succinyl choline is given. Then you observe the fitting in the arm. So that is the correct method of observing. But most of our centers, we don't do that. We just simply observe the seizure, right? So, but that is the theoretical point you need to know. So, and then we have advanced machines. Even this one has a facility to connect out to the EEG. You need another equipment for that, and with that, that would be costly, about 1 lakh rupees or 1.5 lakh rupees, I was told. So then you can see the EEG. So the EEG, you can see the fitting. When the person is fitting, you can see it on the EEG, and you can see when it starts and when it ends. It will be on a printout also sometimes. Advanced machines, as I have worked in UK, the one is called Thymetron. That one gives even not only the printout, as long as the patient is fitting, there is a line comes. That means the seizures is going on, and when that ends, and it will give other indicators also. Seizure suppression index. That means how well the seizure really generalized. So they are giving a lot of importance to those measurements, but these measurements are not available in our apparatus. So we have to look at the EEG and see how far this EEG he is having the fits. I will show the spikes pattern in the next slide, okay? So advanced machines also allow you to choose the time frame and pulse width, all that, but this machine is very simple. You have to choose the amount of velocity, and that much will go. So you don't have to worry about any other technicalities of that. It is like putting an auto mode in the camera, so you don't have to worry about anything. Okay. No, water. Yeah. So you have to understand certain basic physiology, because when you are giving ECT, the anesthetist may not know what it does to the heart, because particularly in some centers, the anesthetist has never given an ECT or anything. So for example, in IMH, we have Dr. Om Prakash, who is anesthetist. He also gives the ECT. He is very experienced with over some 50,000 ECTs now, without a single mortality. So, but not often you are not that lucky. So we need to know some basics, right? So immediately after giving stimulation, there is a transient sinus bradycardia. The heart rate drops, even stops very briefly, but then it is followed by tachycardia due to adrenal medulla catecholamine release, plus also the effect of medicines like atropine, which we give before. So there will be changes in the blood pressure and heart rate. So the BP and heart rate drop initially very transiently, but then they increase very rapidly, increasing to from 30 to 40% over the baseline. So the peak systolic values may even exceed 200 millimeters of mercury. Usually this happens 7 seconds after administration of ECT. The heart rate drops rapidly at the termination of seizure, falling to 50% of peak ictal rate within 5 seconds. So the changes of heart rate and BP, they parallel the seizure. So one can even look at the heart rate and blood pressure recordings, and that gives an idea of the seizure time also. They both correspond very well, particularly if the seizure is a good one. If the seizure is not a good one, then the concordance may not be great. So some instruments even study that and tell that there is a good concordance or not. That is also an indirect measure of effective seizure. So there can also abnormalities of cardiac rhythm and conduction can occur just after seizure induction, and that can include bradycardia, atrial ventricular tachycardias, fibrillations, flutter, etc. So the anesthetist should be ready to should be ready with the right medications, because he should not think ECT means just nothing, I can come and go. So he should, if he doesn't have an idea, probably we should be able to give him an idea also. So he should be ready with all the necessary medications. So when an electric stimulus is given, so when it depolarizes sufficient number of neurons, a generalized paroxysmal cerebral seizure results. So that is what we call as seizure threshold. So that is the minimum amount of electricity which is required to produce a generalized seizure. We are saying just a generalized seizure, not necessarily the effective seizure, right? So it produces, seizure threshold is what is required for a generalized seizure. Suppose if the electricity given is less than required for this one, a subconvulsive stimuli, they elicit EEG arousal kind of response with low voltage, but no generalized seizures. With suprathreshold stimuli, with the right amount of stimulus, there will be hypersynchronous polyspikes occur throughout the brain corresponding to tonic phase of motor seizure. No, that slide is what is happening. So if you have a machine EEG monitoring, so whenever the patient is having good seizure, this is the beginning, and then during the tonic phase, that is what happens. So that is what gives us the spikes. That is most important thing. We should have something like that, right? And then during the tonic phase, during the conic phase, they come down, and finally they flatten. So what the latest machinery they are saying is, if you want to have a good seizure, if you are doing an EEG monitoring, the patient should have like that, and then there should be a drop. Sometimes you may have seizures having one spike here, like this. It may go for 1 minute also, 2 minutes also. That is not effective according to them. To be effective, it has to generalize very quickly, rapidly, and then come down sharply. So this is the advantage of EEG monitoring. You know whether the seizure is really effective or not. Right. So now we'll go into seizure threshold. I have already mentioned how to decide the initial dose. So seizure threshold is an important parameter in ECT administration. It is the smallest electric dosage to evoke a grand mal seizure. It is measured in millicoulombs, right? Initial seizure threshold in most studies, there are various studies to decide what is the seizure threshold for individuals. How seizure threshold varies, that we will see in a different slide. But the studies indicate that the seizure threshold mostly for young people is around 60, but there is a six-fold variation. It varies from anywhere from 60 to even 360. So it is the individual variation is there. So for us to produce an effective seizure, we have to give more electricity than the seizure threshold. We just don't want a seizure, we want an effective seizure. So for that we have to give about 1.5 times the seizure threshold. So if usually if you assume standard adult 60, that would be around 60 into 1.5 will be about 90. So initially probably we start with 90 millicoulombs. Is that right? What is your doing? 60 only. We are a bit, sometimes people think giving less is good. Probably we want to give 60, that's fine. But usually 90 means you will probably definitely get the seizure. So there are some instruments, because seizure threshold varies with the age, there are some instruments which set according to age. If the patient is 30, you put on 30, it automatically chooses 150. If you put on 40, it will have 200 coulombs it will send. So such instruments are also available. Various factors influence seizure threshold. This is very important for psychiatrists, because this is our job mostly. Most of our job is about this one. So if the person is aged, the seizure threshold goes up, because one is the skull thickness increases, and also the brain is shrunk, bit atrophic. So the electric passage between one electrode to one other, there is a gap. So that causes the old age, the seizure threshold goes up. Increases with skull density. Electrolyte imbalance can can impact. Seizure threshold increases during course of ECT. You give one ECT and you give second ECT after 2 days or whatever, the next time the seizure threshold goes up. So usually we make a one increment increase. This today we have given 60. If it is a very good fit, probably we stay at 60. But if we have just reached that 20-second one, so next time we will increase because you may not reach 20. Next time we go for 80 or 90. So that is a practical thing which you will learn over a period of time. Increases with the next one. And there are a number of medications which increase the seizure, like anticonvulsants, benzodiazepines, hypnotics, antiarrhythmics. So this you have to really review before putting the patient on medication. Whenever possible, we have to withdraw all these medications, like if he is on sodium valproate or carbamazepine or benzodiazepines a night before, at least depending on the half-life. So you have to see that there is no such medicines because they will interfere with the ECT. And medications, there are certain medications which decrease seizure also. That is antidepressants. So all the medications which are, for example, chlorpromazine, it can cause seizures, like it reduces the seizure threshold. So if you have a drug, instead of benzos for sleep, you can put chlorpromazine for sleep, or drugs which, so like that we have to make adjustments to help the seizures. Theophylline, that is T, from the T, theophylline is the derivative T, and also caffeine. They both reduce seizure threshold. In rare cases, when the person is not having seizures, then they can actually give them to reduce, to improve the ECTs. But then there are certain risky procedures. Probably we don't do any of them here. And lithium is one which can also reduce seizure threshold, but again we try to withdraw the medication because lithium can increase the post-ictal confusion, and most of the time we withdraw lithium. Anesthetic induction agent can also influence seizure threshold. Propofol and barbiturates, they increase the seizure threshold, and the methotrexate is nowadays preferred because it has no impact on the seizure threshold. VCTs, we don't have to talk about it now because that machines are totally given up because of adverse effects are more. They are not effective in producing seizure also. These are all brief pulse, and they have a fixed pulse rates. So we don't have to worry about that also. The machine delivers what is in it. Okay. Now monitoring of the seizures. So one I told already, we do the direct observation. Somebody observes. Second is, I will give the slides to anyone who wants, so you don't have to take down. And the BP cuff method, I have already mentioned it. So for a motor seizure, the duration is 15 seconds. We aim to achieve a seizure of 15-second duration. If it is EEG monitoring, it has to be 25 seconds. It has to be 25 seconds. There are other advanced machines which I have worked in UK. They have got EMG monitoring facility, heart rate and BP monitoring. There are other measures also, post-ictal suppression index. That is important, sir. Post-ictal suppression index, they keep on talking about it in the UK. So how quickly that endpoint is flattened, it will also give the percentage of it, the thimetron. It has to be above 75%. Then the seizure is really effective. Otherwise, they have to re-stimulate also. So prolonged but weak contractions may not be effective, as seizure generalization may not be good. Okay. Okay. Now this is something which you need to understand more clearly. What are the risks? What are the precautions? And what are the contraindications? Right. There are no absolute contraindications. This is a MCQ question probably, right? There are no absolute contra. Having said that, there are many situations where we don't want to give ECT, right? If at all, if it is necessary, if the risk of not giving ECT is very high, we can give ECT in any condition. But then there are certain contraindications. It is one of the least risky medical procedures under GA, and the risk is considered less than childbirth. The mortality rate is 1 in 50,000 treatments. 1 in 50,000 treatments or 1 in 10,000 patients according to Kramer 85. So This 1 in 50,000 is in Western population, where most patients are elderly. They are all, most of them are 70s, 80s, they come from old age. They are the patients who are severely depressed, not eating for days, ECT administered under Mental Health Act. So our statistics should be much less than that. Having said that, in IMH, Dr. Om Prakash has given more than 50,000 now, not seen a single mortality, because all our patients are young, so the risk is really very, very less. Risks are due to medical conditions, particularly in the elderly, particularly they may be having cardiac problems. So you have to be cautious in patient having arrhythmias, conduction defects, ischemia, heart failure, etc. So for all this, you have to discuss the risk benefit and also seek a physician opinion, right? And severe hypertension is not a contraindication. You can use drugs like nifedipine, nitrates, labetalol, and bring down the hypertension before the ECT also. Stroke, occurrence of stroke is rare due to BP rise in ECT. Post-stroke depression patients respond well with no worsening of medical condition. Several patients who are having stroke less than 1 month were given ECT without any problem, according to Murray. And myocardial infarction, this is important. First 10 days is the risk of ventricular fibrillation or rupture is high normally. Risk is believed to be low after 3 months. I don't think in India we give to any such patients. Basically, most of our patients are young and healthy. In high-risk patients, we don't give actually, we don't give. So some more conditions like aneurysm. So there are numerous published reports of uneventful use of ECT in patients with aortic aneurysm. Untreated cerebral aneurysm that have bled have an increased risk of bleeding. So you have to keep that in mind. So the brain tumors with increased intracranial pressure was considered a classical contraindication long ago due to risk of herniation of cerebellar tonsils into foramen magnum or bleeding. So, but tumors without increased ICP have no risk, right? So tumors with ICP, one has to be careful. Skull defect, if the patient has a skull defect for whatever reason, surgery or something, trauma, place the electrode several inches away from the defect and you can still give the ECT. Neuroleptic malignant syndrome with the favorable results with no difficulties. Pregnancy, no evidence of harm to pregnancy or fetus, even at term. Fractures, yes, in those days when we were giving direct ECT, those days we used to have the fractures. We had one patient in Hyderabad, we remember that patient had a spinal fracture and died, and it was a big issue those days, right? So, but now such risk is virtually eliminated after use of succinyl choline. Drug interactions, TCAs, MAOIs have no complications. Lithium should be discontinued due to severe confusion and prolongs the effect of succinyl choline. Epilepsy patients, they continue their medication. Suppose if the patient is on anti-epileptic, he will continue, because if we remove anti-epileptic and then we give the ECT, the patient may go into status due to unopposed action of this. So pacemakers, the patient sometimes, patient may have a pacemaker. So in that case, you have to be careful that usually we touch the patient, so the patient body should not touch any metal surface or ground or anything. No one should hold the patient. So the current goes from this to this. If there is a touch, the electricity may go through that and go over the pacemaker. So we don't want that. So nobody should touch the patient. So if that precaution is taken, you can give in the pacemaker also. But we don't have such situations in India. Okay, now coming to the informed consent. The general rules of informed consent apply here also. Make sure that patient has capacity to consent. So this proxy consent is not valid actually in UK. I doubt the Indian situation, because only a capable adult can consent, right? we routinely take signature of family members for consent. In one case in Hyderabad, a young man, 26-year-old, has undergone some lengthening procedure, height increase procedure. So in that procedure, he did not take, the surgeon took the consent of the patient, but not family members. So that went into some problem, and they complained to the medical council. The medical council, they suspended the doctor because he did not take the parents' consent. So the doctor has gone to court, and the court had, no, it is not right. The father need not consent. He is an adult capable of consenting. His consent is enough. You don't need parents' consent to undergo surgery or something. But routinely in India, it is a good practice to take consent of the other family members also, because it gives us extra support. But without taking patient consent, we take family consent and doing, that can be that is tricky, and that can be problematic. That can be a problem actually if the patient complains. So most of the time our ECT, the family member signs and we give ECT. The patient says, I am not signing, but we still give ECT. That is not the correct practice. And what if the patient refuses and is under Mental Health Act also? It is not in our MHCA whether we can give ECT treatment with relatives' consent. It expressly prohibited ECT to minors. Minors cannot be given ECT. It prohibited. And it also prohibited ECT treatment under section 89, emergency section. You cannot give, that is prohibited. ECT treatment is prohibited in the list. I don't know why. So that was prohibited. So maybe we have to go to the medical board if the patient is not willing and needs ECT, that is not clear. So you have to explain to the patient what the procedure is. That is, there will be an anesthetist, he will induce medication with sleep, and then we will be given a muscle relaxant. When the muscles are relaxed, we will apply a small dose of electricity. The seizure lasts less than a minute, and then you will be placed in the recovery area. The total duration is about 20 minutes. This is a general description of the procedure. Then you also have to explain about the side effects. So most patients are confused as they recover. It usually lasts less than an hour. Memory for recent events may be disturbed. In most, memory difficulty goes away within few days, although very few may continue to experience memory problems for months or years. No long-term effects on IQ or memory capacity. Don't try to minimize the side effects. Tell them that yes, some patients do have disturbances for memory even for 6 months. So you have to speak what is right. So you also have to tell the mortality risk also. What about 1 in 50,000 in Western studies? Maybe it may be less in our population. That also we can tell them. Results of treatment also, don't exaggerate the benefits. Also tell about alternative treatments and what are the risks of not having treatment. So all that we need to discuss with the patient, and the patient, we have to tell the patient that the patient has right to withdraw the consent anytime also. So it is better if you have an information leaflet prepared by our actually psychiatric society, because it will take away the burden of each one preparing. I have given you one. On the back side is a consent form on the sheet given to you. It's prepared by Chetna Hospital, but it is better if we can have from our IPS TSB or even at a national level. So everyone will tell the same thing, right? So now before ECT, we have to work up. So some principles: confirm the indication and the justification for ECT, rule out contraindications, obtain informed consent by patient. If patient lacks capacity, take nearest relative consent. I discussed already, this could be, it's not very clear whether it is, whether we can do that. Proxy consent is not valid in UK. A second opinion doctor recommendation is necessary for unwilling patient. What happens in UK if the patient doesn't, even if detained under Mental Health Act, if the patient doesn't agree for ECT, then you have to call a second opinion doctor. In the second opinion doctor also agrees, then you can give ECT under the Act. But we don't have such provision in the Act, in the Bare Act now. So I have told that you cannot give ECT under emergency treatment, section 94. ECT for minors and without anesthesia is prohibited by MHCA 2017. So you do following investigations: complete blood picture, liver function test, fasting blood sugar, urea and creatinine, electrolytes, EEG, and additional tests may be required by anesthetist, plus medical opinion may be required. So usually electrolytes, the anesthetist asks very fresh on just a day before, so they have to be latest. The other tests may be done on admission and they are okay, but electrolytes they ask latest. Keep emergency medication, atropine, epinephrine, prednisolone, lidocaine, ismolol for ventricular and atrial tachycardia as required by anesthetist. And we need to have diazepam IV to terminate prolonged seizures or the patient develops postictal delirium. The prolonged seizures usually we notice on EEG recording. Suppose if you are doing physical one, probably if the patient is fitting very lightly also we will miss them. But when you have this continued EEG monitoring and the line goes below it as long as the patient is fitting. So if it goes more than 2 minutes, then you administer slow diazepam to terminate that, because otherwise the confusion will become very bad. So I have never have to do that in UK also, so probably it is rare also. Stop benzos a night before, and patient should be on NBM for 8 hours, okay, because he is undergoing general anesthesia, he is on general anesthesia. So what about the ECT setup? So ideally you should have a waiting room with a toilet facility, and there is a treatment room and there is a recovery room. You need a psychiatrist, anesthetist, a nurse, and 2 or 3 supporting staff. The equipment is Boyle's apparatus, you can see there with oxygen supply, and you have a cardiac monitor and defibrillator. These are ideal. And psychiatrist is responsible for choosing the electricity dose and stimulation. The anesthetist is responsible for induction of anesthesia till recovery. Nurse generally does the record keeping, and psychiatrist generally manages prolonged seizures, postictal confusion, headaches, etc. Usually when the patient is into the recovery room, the anesthetist, they go away. If there is any problem, as medical people, we will see that. Right? If there is any confusion or patient is restless, we will deal with it. So coming to the procedure, line by line. So on the table, verify patient details, because wrong patients may come. Check the consent form whether it is properly signed, because sometimes staff can just assume that is signed and from the ward he may come. And so check consent form, see all the investigations are done or not, right? And of course anesthetist also does it, but we should also do. Verify whether the patient is nothing by mouth, because some patients may without telling anybody, so it is better to keep him on watch for the last 8 hours so that you won't drink any water, any food or anything. So ask the patient to empty bladder, remove dentures, loose tooth, chewing gum, because all this can, if they go back and they fall back, there can be a real problem. Anesthetist may require cardiac monitoring, pulse oximeter. Then the anesthetist applies the IV cannulation, and you loosely apply BP cuff, right? And connect any monitoring leads like EEG leads, EMG leads, whatever, depending on your machinery. Now the anesthetist administers pre-medication, which is atropine or glycopyrrolate, one of them, followed by sedative thiopentone or methotrexate. In our center we use thiopentone, isn't it? And we also use glycopyrrolate and thiopentane. And then inflate the BP cuff 10 millimeters above systolic pressure. Administer succinylcholine chlorine 0.6 milligrams per kg body weight as rapid bolus. This is all done by anesthetist, the administration of all these drugs. So meanwhile, you start cleaning the skin. So you take a saline, take a cotton, dip in saline, squeeze the saline out, and rub on the area where you are going to apply. You rub thoroughly so that some amount of skin excoriation will also happen, right? Some amount of all that grease and all natural. So that would facilitate the transfer of electricity. And set the electricity of on the machine, set according to age or whatever, 60, 90, and then place the electrodes as shown on the figure, and then you press the treat button. Press the treat button, and then the staff members will watch the seizure, right? So, as I said, effective motor seizure should be 15 seconds, and if it is easy monitoring, it has to be 25 seconds. If you see that the patient did not have enough seizure, so what you will do? So you ask the anesthetist, the seizure is not good, I am going to re-stimulate. So the anesthetist immediately ventilates the patient with oxygen, right? And then usually within a minute, we do the second stimulation, usually between 30 to 60 seconds. So then again, if the patient doesn't have good fit, then again you increase the elasticity to next level and you do the third stimulation. The repeated stimulation and the ineffective stimulations, subconvulsive stimulations, they do more harm than good. Actually, many people are under the impression, I have seen particularly in UK, there they were very afraid of ECT procedure. They were giving smallest amount, then the patient doesn't fit. Then just a slight increase, another fit. Actually, the text has said that give proper treatment, have nice. But first day they won't get fit. Second day after second, they used to take quite longer time. It does more harm than good actually, because the subconvulsive stimuli produce more confusion and the cardiac risk also increases. I have to tell one case about in the IMH who has died, not under Dr. Om Prakash. In those days, in Institute of Mental Health, the non-psychiatrists used to come to IMH because there were plenty of vacancies in IMH Hyderabad, and nobody wants to leave Hyderabad. So when they get a transfer, they find this Erragada hospital has got a job. So they come into Erragada hospital. They are gynecologists. One is gynecologist actually. This gynecologist. So they don't have any psychiatric experience. So Dr. Raghuram Reddy sir used to say, okay, this is physical treatment. If you cannot do psychiatric this assessment and all that, at least you learn ECT and give ECTs. So one of the ECT was given by one such lady. She has given 1, 2, 3 stimulations. Third stimulation, patient died. So this is the only death I've come across. Probably maybe she has given 3 or 4, we don't know. But beyond 3, I think we should not go. Right? We should try to get the ECT, the seizure in the first instance itself. Don't try to look for. Don't think that giving less and less is better. Right? So that impression is not correct. So this is the you have it in your paper. So this is the record we maintain in Chetana Hospital. So the serial number, the date. So we put the ECT voltage, duration in second, but actually it should be millicoulombs. Actually we are not doing that. It should be just millicoulombs, 60, 90, whatever. Actually we put the figure 60, 90 only. That is not right. And thiopentone, propofol, whatever is given, the anesthetist fills up the atropine, and the duration of convulsions, recovery, that the psychiatrist will fill up, and like that you maintain the record. So you should also have a register also. Apart from this, you should have a register, ECT register to maintain. So why a seizure fails? So when a patient fails, that it could be the stimulus intensity is not enough, so it is less current than required. There may be excess or low impedance. What is impedance? Impedance is due to the thick skull or whatever. So the electricity doesn't pass between one electrode to another electrode. There is a lot of resistance. So that is usually due to the grease or hair. Hair, suppose if the person has a very thick hair, unless you can manipulate this under hair. You can push this one under hair. Suppose the hair is there, you push under hair. Otherwise, if you put our hair like this, the electricity doesn't pass properly. So those small things are important. And also, impedance can be sometimes very low. Actually, the equipment which I use, they allow you have to do the impedance test first. Sometimes it can be very low because the electricity from one electrode to another can bypass. If the person has a lot of grease or some conducting substance, it can go from here, and even without high stimulation, you may not get seizure. But that rarely happens because we are using bilateral. That is very unlikely, but unilateral, it can happen. From here to here, it can go directly between one electrode to other. So that is, impedance can be high. Remove excess oil, hair, roughen the skin. Premature stimulus termination. So sometimes person may withdraw that before the entire electricity is passed. So 1 second can be a long time sometimes. So then also it can happen. So you hold it till the whole thing is over. Excess anesthetic agent, or if you are using the arm method, the cuff has failed to stop the circulation. Increase of seizure threshold by previous ECGs may be the reason. Other factors like drugs like valproate, benzos use. So you review all these things for your next ECT. So this is one slide I thought bit more on memory, because most of your doubts or patient doubts will be around that. So transient memory disturbances for events immediately before and after the course of treatment, clearing within a few weeks. So this is generally expected. At worst, significant memory deficits for a period extending 6 months or more before ECT. That is retrograde. Retrograde to 2 months anterograde. So the person 6 months before ECT events also he may forget, and 2 months anterograde also he may have problem, and which may persist even for 6 months or even longer. So these have been recorded. So we don't deny that there is nothing like a memory disturbance. It can happen, but most on bilateral ECT experience permanent memory gaps anterograde for some events occurring during treatment days. So if you are giving, the treatment is given for a week or so, so during that period what has happened, the person may not able to recollect after some time. So that can also happen. But patients can be reassured that no permanent effects on new learning and other cognitive functions, that is intelligence, reasoning, judgment, comprehension, visuomotor and perception. So usually patient doctor, does it affect my future learning, future memories? That we can reassure between that, as long as you are in hospital, and these days you may have, but after that there is no permanent effect. This is according to Abrams electroconvulsive therapy book, and Abrams is a kind of electroconvulsive therapy. Abrams is a standard textbook. Anyone is interested, you can search it on Google and you will find it. So how long you give the treatment? How much time? Yes, okay. Treatment is usually bi-weekly, that is in UK, and it is in India and USA it is alternate days. So probably UK is more leisurely compared to America. America is more private, India is in between, but we also want to, our patients are in a hurry. In Yaragada hospital I used to work, and I was in charge of the family ward. I'll tell you, this is to tell how effective ECT is. And I used not to write ECT just immediately. After 4 days or 5 days, the family members will come to me. They see the other fellow getting ECT and improving within 2 or 3 ECTs, particularly Mannix. So then one of the ward boys is coming, sir, he's my relative, give him ECT, sir, give him early ECT. Then I realized that all these relatives watching them are catching the ward boys, giving them some money, and he's bringing them as my relatives. Then I started giving them ECT quicker, within 2-3 days, because these people want to go away quickly to their homes. So we give alternate day ECTs. So in hospital also, private hospital also, we give alternate days because hospitals stay costs them. So usually we give, if you are giving an outpatient, you can plan twice a week, because that will allow the full effect of the ECT to come, and probably the confusion is also less. So we can plan twice weekly if it is an outpatient one. But if it is inpatient, we generally it is once week. Rarely you may have to give daily ECTs also. And there are some cases where you give multiple ECTs, 2 ECTs on the same day. Give one ECT, you have a proper seizure, but then after 1 minute you give another proper seizure. So that is 2 ECTs in one session. But that is only for theory's sake I am talking. Okay. Then there is another important called maintenance ECTs. So some patients, particularly severe depressives, melancholic depressives, they respond to ECT. Probably they have not responded to other medical treatments. And such people, probably it is better to have them on maintenance ECT, because this is have far less side effects and a better recovery than using all the medication. Sometimes, most of the time, ECT has far less side effects compared to high dose of TCAs or other drugs. So, key point is, the ECT is an effective modality of treatment, but you have to choose the right patient, you have to take the informed consent. EEG monitoring should become a norm, that is because there are other advantages, not clinical efficacy we can really read better with the EEG monitoring. So it is important to achieve good generalized seizure with adequate stimulus. Feeble but lengthy seizures may not be effective. And don't forget to remove the cuff after seizure monitoring. Suppose if you are using cuff method, leave the cuff inflated, particularly with the BP apparatus like this. You can leave it, this also goes on the tray, on the trolley, and the person may have gangrene, right? So if you are using cuff method, it's better to have a stand one so that it cannot go with it, right? So somebody has to take responsibility for the BP cuff. Okay. Thank you. If you have any.
Thank you, Dr. Keshwara. Very comprehensive and very elusive presentation. Before I go about some few points which I might add to whatever Dr. Keshwara said. Okay, the first thing is about the mental health care bill, where we have ECT cannot be given as an emergency treatment. Emergency treatment is only in that section where the patient is being transported from one hospital to the mental health facility most of the times. And in case of minors, if the ECT has to be given, okay, it has to be with the permission of the mental health review board, and then the consent of the parent. Both of the things have to be done. In a supported admission where a patient doesn't have the capacity to consent for ECT, if there is an advance directive from the patient that he can be given ECT with the permission of the family members, it can be given. Okay, that is one more thing. And if he has a capacity to consent, that means you have assessed the capacity and he has a consent, he refuses ECT, you cannot give ECT. Okay, so these are some things about the legal aspects of the thing. And about this machine, okay, the ECT machine, this is the standard one which all of us we use. Okay, so the starting point which usually whenever the switch off and switch on the machine, it starts at 2, which is 120 millicoulombs. Okay, if you can see it starts at 20. We generally start with 60. Actually, you can go for lower ones if you are taking young people like 16-year-old, 17-year-old. If you are starting ECTs for them, you can go with 0, which is 30. Okay, and then automatically once you press the thing and then you leave it, oh, it's not connected, sorry. So once you press and leave, it automatically steps up by itself. One thing to remember is that to watch for seizure, you have to wait adequately. Once you have given the current, okay, the patient didn't have the seizure, you're monitoring the limb didn't give the seizure for you. So immediately you shock him again, you might not get a seizure. You have to wait for complete 15 seconds before you actually give the second seizure. Why is that? Because there's something called absolute refractory period. If you depolarize a nerve and then you want to give another stimulus during the absolute refractory period, it will not generate another thing. So if you're not waiting for that 15 seconds, you might not be able to. Second thing is that there is a delayed onset of seizures in some patients. Some patients don't get the seizure. The moment you leave the thing, you can't see the seizure. Okay, it will take some 5 seconds, 10 seconds to build up that seizure because generalization takes some time. Okay, so you might be missing an adequate seizure okay, by shocking him again. So giving a higher stimulus in such cases might actually lead to more of cognitive deficits, okay, which might not be good. Okay, the electrodes are by concave shaped, convex shaped, because the concave shape of the temporal bone which we have, it fits into that. Okay, this is a bilateral temporal ECT which you give. There's one more modality called bilateral frontal ECT, where you give, there the shape of the electrode need to be different. Okay, bifrontal is supposed to be less cognitively side effects than the bitemporal because of the generalization taking place. Pre-oxygenation, whenever we are giving ECT, pre-oxygenation is a very important thing. We need to educate the anesthetist, because a lot of times they give the anesthesia and then say, sir, give. Okay, if you give pre-oxygenation, the seizure threshold actually reduces and it gives you a better seizure, and then the cognitive deficits are a little less. Okay, and whenever you are posting a patient for ECT, night dose of long-acting benzodiazepines, let's say somebody is on diazepam, clonazepam and all, it's better to shift on to a short-acting one, so that the effect of that benzodiazepine is not there the next morning if he requires sedation in the night. And if you are giving valproate or some other medication, drop the night dose of the medication just before the ECT. You can give it on the next day. And there are some studies which says that lithium and ECT have a adverse cognitive side effect, but the benefit risk ratio has to be assessed, and then depending upon that we usually give the ECT. With this I open for any questions and queries from the PGs. Is there anybody who didn't see an ECT till now, witnesses ECT? No. Can anyone tell me what is the non-psychiatric indication for ECT? Anyone? PGs only. Okay. So it's actually used for refractory seizures. Okay, so neurology, it is used for refractory seizures and Parkinson's, severe Parkinson's, where on and off phenomena is very high. It's used there as well. Okay, so it increases the seizure threshold. So it indirectly treats seizures. Okay, so all the psychiatric indications are on one side. So this is the non-psychiatric indication.
Jaundice is also one.
Jaundice.
One of my professors, Dr. K.P. Dave, at their time, long back in 1970s and 80s, for almost everything they had tried ECTs. So jaundice was one of the indications. But Parkinson's, yeah.
Yeah, Parkinson's.
NMS, neuroleptic malignant syndrome,
Yeah.
ECTs, yeah.
I talked of non-psychiatric, so I didn't use an NMS. Okay, fine. But definitely this one. Okay, and then about twice weekly, thrice weekly, the efficacy of thrice weekly and twice weekly is same. So the efficacy wise it doesn't make a sense, but time wise for a patient who is inpatient, who is wanting to have a quicker discharge, you give alternate day. As sir said, outpatient you can look at twice a week ECTs. Okay, but daily ECTs, multiple ECTs in the day are not at all recommended, because they are not efficacious, and then they have high morbidity of cognitive deficits. So if you look at efficacy studies, it's the bi-weekly or the thrice a week thing which is actually recommended by the thing.
There was something called as regression ECTs, wherein ECTs were given in a day. Multiple ECTs.
Multiple ECTs were. These all practices were there before they came up with the research as to ECTs. Effectiveness studies were there, which showed that these things. There are a lot of theories behind the thing, and then psychological theories are also present behind ECTs, but right now we talk about more as a biological treatment, and then the effectiveness and efficacy when you compare data on various modalities. So sine wave ECT has gone, we have come with rapid brief pulse and ultra brief pulse ECTs, okay, and then twice a week, thrice a week. Okay, these are the things which we talk of.
Yeah, sine wave, some people still use sine wave for better, faster and better recovery. Some claim that sine wave is more effective. Brief pulse, yes, we use brief pulse. Ultra brief pulse again coming down. They say that with ultra brief pulse you don't get that much efficacy. The efficacy wise as well as things are not that good. So they have come to brief pulse, and we have stopped at brief pulse.
Most common used is brief pulse. This machine is a brief pulse machine. Okay, and most of our Indian psychiatrists use the brief pulse machine. Sine wave requires more power, more current to deliver the same amount of seizure. So that's found to be having a little more. It is not about the efficacy, is not different between the sine wave and the brief pulse. It's only the cognitive deficits which are better. There's some studies which talk about efficacy might be say more with the sine wave initially, but cognitive deficits is what they talk about.
Yeah.
Sine wave has disappeared from the Western scene.
Western scene, but Indian scene, it is still there. Sine wave machine is comparatively lot cheaper
How much,
than
how much does it cost? This one?
sine wave machine costs 7,000. Brief pulse from start like 25,000 at least. Yeah, there are various range. EEG monitored is around 1.5. And yeah, as sir was saying, sub threshold, there are studies between sub threshold and supra threshold. So supra threshold was found to be more damaging cognitively. So some prescribe sub threshold, like just on the verge when you get.
I think now they are focusing on the proper seizure generalization. That is what their focus is. So if you achieve that, that is enough. Yeah.
There was one practice in Bombay wherein you give bi-weekly or every alternate day, but there is something called as maintenance ECT, wherein you keep on giving ECTs for life. So once in a week, then gradually shift on to once in 15 days, then once in a month. There is one a leading psychiatrist, Dr. Parker. He used to give once in a year. So patient used to come once in a year to charge their batteries.
Now, the advanced machine Thimetron is available in India also, but it costs something like 30 lakhs or something. 30 lakhs or something. The one I used in UK, I looked at the price. It is available in Delhi, but it costs too much. All these parameters, the EEG, it beeps, it gives all the beeps. Suppose when a line runs, when the patient is having a line goes on shows, and then if it is more than 2 minutes, it gives a beep, so it alarms you. And there is a seizure suppression index, and all those parameters like concordance, heart rate monitoring, all these things are available in that. But it is not necessary. It's too costly. What we need is EEG monitoring, and we can observe the spikes, which is very easy. Yeah.
There is a computer-linked system wherein you can even have the total medical record in the same system, and so that you can review next time at what days you have to start. That's why it's very costly. Yeah. It's a computer-linked one. Yes, EEG is also incorporated in that. That's why it's costly. EEG itself will cost 1 lakh.
As computer connection, sir, we used to book the appointments, and also EEG could be recorded, but I think they quoted around 2.25. So they don't have all the parameters like heart rate and other things, but EEG with computer connection.
So the EEG and monitoring of ECT is a different system. The monitoring system is a different system. Okay, so it will go up to how much ever you want. The sophistication is more. The preciseness is more, like you can calculate the impedance, exact seizure threshold where you are getting, and when you are having to terminate a seizure, let's say it's going more than 2 minutes, you have to terminate a seizure as well by giving extra lorazepam or giving extra medication. You will have to terminate the seizure also. Somebody was asking. See, the basic problem is that you can't give a direct ECT. If you were giving direct ECT without anesthetist, it was okay. That's why direct ECT was more popular before the Mental Health Act actually said that you can't give it with or the Supreme Court verdict came out that nobody can be given as a direct ECT. So if indirect ECT has to be given, he has to be given succinylcholine and you have to be ready to intubate. We had to intubate patients sometime when they are not recovering out of the succinyl colon because you didn't know whether they were actually vicious or whatever the reason, the acetylcholinesterase enzyme is not high. So anesthetist is a very important factor. Without an anesthetist, there is no point you are giving. Unnecessary risk you are taking, you will going something illegal according to the mental health care bill if you are doing it. Thank you. Dr. Sri Krishna, Sai Krishna wants to say something.
Good morning, sir. I want to add one point, sir, regarding anemia. I had bad experience in 2011 when I was a postgraduate. I was attending IMH postings. There, after ECT, one patient had collapsed because of anemia. So every postgraduate should remember whatever the indications for general anesthesia, which you do in a surgical case, you are supposed to work up all those things. You should not miss. And second thing, regarding the consent paper, sir, I want to know whether a printed consent form is valid. Generally, they say that you are supposed to write in handwriting, but in psychiatry, consent itself is a tough task. So I want seniors to opine on this point, sir.
Printed and it's
Printed
a format.
consent. Why? Because you are having a typical format, which we type in either English or Telugu, whatever, depending upon the hospitals. But it is not valid from my knowledge. I request seniors to add this point.
So I think you're talking about the legal aspect,
Yes, sir,
where
legal
they,
aspect.
they told that the printed high risk consents which were being taken before surgery,
Yes.
they're all on the same standard and there is no specific indication according to each patient as to why you are doing it, what you are doing it, what is the exact procedure you are doing it, and that is not reflecting in the consent.
Yes, sir.
That is why it is. But the printed format of the ECT contents is very comprehensive. Okay, like I don't know whether we can use, because in that sense every consent you have say, I have diagnosed you, I evaluated you, you have this problem, these are the indications for your case, and that is why we are recommending ECT, and these are the side effects, and each of the patient will have an individualistic consent form. So you want to say something, sir? I can.
If the chairperson permits, I request Chandrasekhar sir and Ashok Reddy sir to comment on this point.
One minute. I think in that probably we have to write indication, number of treatments advised. That would be better. What is the indication also we should write probably. Probably that format doesn't have indication.
Yeah, what that Sai Krishna is quoting probably, recently there was one judgment about one corporate hospital. That's why you are mentioning about it. See, it is informed written consent always. Information should be very clear. It can be printed form, they cannot object it, but information is incomplete. That's why the objected is. Information, if it is very clearly specified what we are doing, what alternatives are there, and whether they can stop in between, like that, if they don't want a third ECT, they can offer. All these things should be clearly informed, then printed consent is valid.
I think it was about blanket consent.
Thing, especially according to the NABH guidelines, another thing is, you can't take a blanket consent for 6 procedures. So every ECT should have a consent sign. Suppose I am giving 6 ECTs, because 6 times I am giving anesthesia. So every anesthetic procedure needs a consent. I can't say I have taken an anesthesia consent 3 days back for the first ECT. So it is imperative that whenever the patient comes for the next ECT, again sometimes to save the trouble, what you can do is put the date for the next ECT and take another signature. The form can be used, but you need a signature and dated for every ECT. That is important. Another small general information, if you want to reduce the cognitive deficits, sometimes we use giving intravenous nootropill, Pericetam, which is helpful. This was published long back in BJP, several decades ago, but still it is a useful technique we often use, especially if there are professionals who have to go back to their work, then it is useful that after every ECT, you start a drip, putting one ampoule of Pericetam in that will be helpful.
Adding to what Chandrasekhar sir has mentioned, in Pratima we are doing this for the past 2-3 years. Before every ECT we take the consent, like it is not a blanket consent, because blanket consent is where the objection from the court arises. Every procedure, suppose we are doing ab reaction also, separate consent is taken. Anything what we are doing, any procedure, the consent is written in the native language of the patient, either printed or handwritten. Another one point I want to highlight is ECT can be used, when I was working in Kerala, they used to maintain 150 patients in one setup. So the way how they used to maintain patients is, if any patient becomes violent, the answer is giving ECT. See, that is one pitfall of that. See, there should be proper indication why you are using ECT. So there can be any procedure, there can be positive and negatives, but you concentrate on the whatever the indications are. Thank you, sir.
I think we had good discussion, and then the topic was very, last question, yeah. Two people, yeah.
Anesthetist were telling only ketamine will be enough, but we were asking for muscle relaxant also. Anesthetist was like, ketamine has muscle relaxant properties, so there is no need for succinylcholine or something. So what is the ratio?
It is general anesthetist call. You are there to give the ECT. Okay, anesthesia part is the anesthetic. He is taking a chance that this is what I am comfortable with. I am comfortable with propofol, glycopyrrolate and succinylcholine versus I am comfortable with ketamine. It's his call what he wants to do, because the anesthesia part, he is responsible. You are responsible for the electric stimulation and the side effect on that sense. Yeah, last one.
Good morning, sir. Sir, is there any indication for chronic pain conditions for ECT?
You want to say that?
Chronic pain?
There is no specific indications for chronic pain in that sense, but some of the patients, like the TDCS has been used more commonly in the somatoform pain disorder, where repeated stimulus headaches especially. Okay, there it has been used, but ECT has not been. Okay.
Thank you, sir.
Sham ECT as a placebo. Sham ECT, just do.
As a placebo. Okay. I think we had a good discussion and a very informative session. With this, I close the session. Thank you, though, for the organization. Yeah.
I request Dr. Gangaram sir to present a token of appreciation to the speaker and the chair. Thank you, sir. Chair. So there is EC meeting happening in the lecture hall 4 in the next gallery. ఇప్పుడే ఒక 2 minutes. So moving on to the next session. So the second session is on RTMS use in psychiatry, and the session will be chaired by Dr. George Reddy, sir. Dr. George Reddy, sir, is a renowned psychiatrist with more than 15 years of experience in this field. He has done his MBBS from Kaktiya Medical College, Warangal, and DPM from Guntur Medical College, Andhra Pradesh. Currently, he is a successful private practitioner in Hyderabad. He is an active member of IPS TSB and HSP. He has been president of HSP in the past and current vice president of IPS TSB. He is a treasurer of Telangana Private Psychiatry Hospitals and Nursing Home Association. His areas of interest being substance abuse and de-addiction, in child psychiatry, ADHD, autism, and intellectual disability. So I would like to call upon the speaker of this session, Dr. Sandeep Kondepi. I request George Reddy, sir, to introduce Sandeep Kondepi, sir.
Good afternoon. Before I introduce the speaker, first I thought I'd just share my experience with this today's topic. Initially, when people were talking about RTMS, I think might be like everybody, not much of awareness regarding this procedure. There are many jokes which are made on the WhatsApp groups and just like that RTMS was nothing but an expensive placebo. This kind of vague comments are made. And so many things took place. And at that time I remember Dr. Chandrasekhar sir even trying to explain to us what is this. But later, one of my close relative, she was a known case of chronic paranoid schizophrenia. I think I tried to treat her for about 8 to 10 years. But I think not much of improvement, but she did have some reasonable quality of life. And then I couldn't do much. Then I referred to Dr. G. Prasad Rao sir at Asha Hospital. And there, I think sir did the routine treatment. And there, first time I came to know that he used RTMS in this patient. And it was a long journey, but there's a lot of improvement after the procedure was given at various sessions. And that's how I think then we started to learn about the RTMS. I think definitely an apt topic for all of us to know, because very less procedures, we thought only ECT was once upon a time considered that we all psychiatrists have an option. But now there are many more procedures which are picking up and might be definitely with evidence. It's not that simply we are trying to look at, and we should all feel proud that one among the few centers in India, I think we are proud that in Telangana, Asha Hospital has this facility, and we are getting a chance through them to learn what this procedure is. So I will introduce the speaker today, Dr. Sandeep. He did his MBBS from the same medical college, SVS Medical College. Sandeep, welcome back to your mother institute. And then later he did his MD psychiatry from Narayana Medical College. And later he joined Asha Group and is the consultant and an addiction specialist. And he is the in charge for the neuromodulation there. And he did his advanced course in management of addictive disorders at NIMHANS. And is a member of Addiction Psychiatry Society of India, and is a member of American Society of Addiction Medicine, and he did his fellowship there, hands-on training for transcranial magnetic stimulation at AIIMS, Delhi, and he did a certificate course in motivational interviewing in addictions. And I think I'm fortunate that I'm here with Dr. Sandeep. I heard to one of his excellent session in one of our Hyderabad Psychiatric Society. I think there are a lot big giants there, and firing a lot of bullets at Sandeep. But the best part, he was just so relaxed, and I think he could answer to many of the questions. And fortunate that he's here again to talk to us in practical and demo about the procedure. And with not taking too much of time, I think I would ask Dr. Sandeep to go ahead with the presentation.
Yeah. Yeah. So first of all, thank you so much, George Reddy sir, but he gave an exaggerated CV. I'm just a growing bud in TMS, field of TMS, because TMS is a evolving science, like it's like an ocean. So, and I also thank Ashok Reddy sir and Dr. Chandrasekhar sir for giving me the opportunity. And I thank the entire organizing committee, IPS TSB, and the EC members, SVS Medical College, Asha Hospital, my seniors, teachers, and colleagues. So today, is it audible? Is it clear? Yeah. So today my topic is TMS. TMS. So before going, I'll make the session. I'll give a presentation, PPT presentation, and also I'll show a video demo. We thought of bringing the TMS mission to Mahboob Nagar, but it was not practically possible. But for sure, with the permission of Chandrasekhar sir, in future, we'll have a hands-on workshop in Asha Hospital. So TMS is transcranial magnetic stimulation. So it is a neuromodulation. So what is neuromodulation? Anything which modulates the neuronal activity of the brain, it is neuromodulation. So neuromodulation has ECT, has TDCS, has DBS, has VNS, has TMS, everything. And it is a neurostimulatory. So with the help of magnetic pulses, which are generated by a coil, from the exterior, it passes transcranially into the brain to stimulate the brain. So it is neurostimulation and a neuromodulatory. So any time to stimulate the brain, you need two things. You need a current and you need electrodes, right? ECT, current, electrodes. TDCS, current, electrodes. DBS, current, electrodes. VNS, current, electrodes. Everywhere you need a current and electrodes to stimulate the brain. But the magic thing of TMS is the current, the electricity is converted to magnetic field, and this magnetic field passes through the brain and stimulates the brain. So it is brain stimulation without electrodes. Okay? So you can remember this line, current, magnet, current. You'll understand it later because the entire mechanism of TMS is based on this line. So brief about brain stimulation. Towards the right side are the most invasive, the surgical procedures. In between is invasive and convulsive procedures. And this is non-invasive, non-surgical. And if you go to the top, they're more focal. Okay? So to the rightmost, if you see DBS, deep brain stimulation, they'll place a pulse generator in your chest. The wires are passed underneath the skin of the neck directly into the skull, and they place the electrodes inside the brain. So DBS is used for depression, OCD, epilepsy, Parkinson's, chronic pain, and many other things. When it comes to VNS, is vagal nerve stimulation. The same thing, they place a pulse generator in your chest. These are surgical procedures. So they place a pulse generator in your chest. The wire goes underneath the neck, under the skin, and attaches to the left branch of vagus nerve, the 10th cranial nerve. Okay? VNS is used in depression, epilepsy. Optogenetics, I will discuss in the next slide. And ECT, as Sir Keshavara sir has given an elaborative discussion. MST, is something similar to ECT, but in ECT we are giving direct current, right? In MST, we are converting this current into a magnetic field and we are giving high frequency magnetic pulses to a target part. In ECT, we are giving it directly. Here we are focusing on temporal lobe or motor cortex. So this also requires anesthesia and it's an invasive procedure. And MST claims that it has less cognitive deficits than ECT. Okay? So it is directly giving high frequency magnetic field to your motor cortex. And when it comes to TDCS, it is transcranial direct current stimulation. Anyways, they'll discuss in the next session. It also has 2 electrodes, cathode and anode, and we are giving low voltage current to your brain. And RTMS is a current topic of discussion. And FUS, now it is in evolutionary process in psychiatry. It is focused ultrasound surgery. Though they named surgery, there's no surgery at all. It is completely non-invasive. Like gamma knife. In gamma knife, you are giving radiations. Here, you are using ultrasound waves, and it causes a thermal ablation. Okay? You are using focused ultrasound waves. So, as I said, vagus nerve stimulation is invasive. Now, it has been non-invasive also. So now this is the gamma core. Now you can directly stimulate, you can see the carotid pulse beneath the behind the sternocleidomastoid. It's just like a remote, it's like a trimmer. You can just stimulate your vagal nerve. So it has become non-invasive also. It is FDA and CE approved now. So as I said, optogenetics. Optogenetics is nothing but light interacting with genetics. So they pass some genetically engineered opsins, which are light sensitive to your body. And with the external light, you can control your neurons. So with blue light, you can open the ion channel. With the yellow light, you can close the ion channel. Now they are working on blindness and retinitis pigmentosa. They're working on depression and they're working on Alzheimer's. So, as I said, brain stimulation requires electricity for sure, current. If you are giving direct current, this ECT, TDCS, VNS and DBS. If you are converting this current into a magnetic field, MST and TMS. So, the history of electrical stimulation is very fascinating and interesting. It was first identified hundreds of years ago when the Egyptian fishermen, when they were going for fishing, once they came back from fishing, they felt that the body cramps are reduced. So in that area, there were many electrical eels and stingrays. So they identified that these stingrays and electric eels are releasing some current. So there is a reduced in body cramps. So they started investigating this fish. Like the top one is a catfish, this is the bottom one is an electric eel, that is a stingray, and the rightmost is the king of rays, it's the torpedo. They called, ancient time, Greeks and Romans and Egyptians called it as healing fish. They used it for everything. If you have a migraine, they used to put a live torpedo on your head. On a gestational pains, they used to put a live torpedo on the stomach. And they used to dig a tunnel for arthritis, and they used, because salt water is a good conductor for electricity, right? So seawater, they used to put seawater into that pit, and they used to put the legs with a live torpedo. Okay? So, but electromagnetic stimulation, the history started with Faraday. You know the Faraday's laws, right? So I'll make it very simple. Electricity and magnetic field are very close to each other. So any electric field can produce a magnetic field. It's okay. Yes. Any electric field can produce a magnetic field, and any magnetic field can produce an electric field. But the rule of thumb is the electric field should not be static. Okay? It should be fluctuating, pulsating. So on and off current can produce a magnetic field, and on and off magnetic field can produce an electric field. This is the Faraday's law. So in this here, if you take a coil and a magnet, It cannot, the magnet cannot produce the current in the coil. The magnet should be moving in and out of the coil. So when the magnet is moving in and out of the coil, there is on and off magnetic field for the coil, right? So once there is an on and off magnetic field, Faraday's law, current is produced, right? The reverse of it, when you take a coil and pass current, when the current is static, there is no magnetic field at all. When the current is on and off in the coil, it produces a surrounding magnetic field. So it is vice versa. So TMS is not just a static magnet on your head, okay? So as I said, there should be a change in electric flux. So last 2 decades, last 3 decades, there was a lot of marketing for magnets. Magnetic shoes, magnetic belts, magnetic watch, magnetic bed, everything. But this is not TMS. TMS, there should be a change in electric field to produce a magnetic field, and there should be a change in magnetic field to produce a electric field. So during the early 19th century, there were a lot of experiments with magnets. So by the end of 19th century, approximately 1984, he is the founder and he is the father of TMS, and he coined the term TMS, is Anthony Barker. So he started, invented a machine. It has a stimulator and a wire connector and a coil in the hand. So he started stimulating the motor cortex. So if you stimulate the left motor cortex, there was movements in the right hand. So they found that the magnetic pulses can stimulate your brain. So he was the founder of TMS in 1984 in University of Sheffield. So as I said, the first line, current, magnet, current. This is the meaning. First, there is a primary current. It is on and off. It is creating a magnetic field. And this magnetic field, as the current is on and off, even the magnetic field will be on and off. So once the magnetic field is on and off, it creates a secondary current. Okay? The same thing happens in TMS. Now the coil, current in the coil, if you make it on and off, it creates a magnetic field. If the magnetic field comes in touch with some conductor, our body is a very good conductor, we have a lot of ions, right? Once it comes near the brain, it can create a secondary current in your brain. So without the help of any electrode, the current is converted to magnetic field, and this magnetic field is activating your brain. The neuronal activity is the second current. So in this diagram you can see the current in the coil is creating a magnetic field around the coil. The magnetic field, when it touches the brain, when it passes transcranial and touches your brain, it creates a secondary current, that is the depolarization of the neurons. So when you take the timeline, as I said, Anthony Barker was the founder of TMS. He coined the term TMS. And later, what did Anthony Barker do? He stimulated the motor cortex, right? So Pascal and Leone, now as humans, they try and experiment everything, right? Now Pascal and Leone started stimulating the Brodmann's area, 45-44, the Broca's area. So they saw speech arrest. Immediately when you stimulate, there was speech arrest. And also, then Pascal and Leone found that when the pulses, if you give a single pulse, there was a speech arrest. And he said once he was giving continuous pulses, the speech arrest was also for long standing. Even after 45 minutes or 20 minutes, there was speech arrest. Then this was a milestone moment. Then they found that if you give repeated magnetic pulses, you can have long standing effects in your brain. So then George and Kolbinger started stimulating the dorsolateral prefrontal cortex during 1995 because it was the most identified part of the brain which is hyperactive in depression. The dorsolateral prefrontal cortex, the left dorsolateral prefrontal cortex is hyperactive in depression. So Kolbinger started stimulating it, giving it multiple pulses, and they found that there was a decrease in depression in most of the patients. And then the TMS arrived into the market. 2002, Canada, it was approved by Canada, and 2008 was the first TMS machine approved by FDA for depression. Because there were n number of sham studies, there was n number of monotherapies done. After that, FDA has approved, okay, finally it is working for depression. In 2010, APA, American Psychiatric Society, has included as a mainstay treatment for depression. 2011, it was CE certified in Europe. 2013, it was approved for migraine. In 2013, it was approved for, another coil was introduced, which is a H1 coil. I'll explain it later. It's a helmet. For depression in 2018, Express TMS. Before, they used to give pulses for 20 minutes or 30 minutes. Before 2018. From 2018, there's a new method called Express TMS where you can, the treatment protocol is only for 3 minutes. It's an Express TMS. So 2018, again, one more coil was introduced, H7 coil for OCD. And 2020, H4 coil for smoking, and also they introduced a double cone coil for OCD. I'll explain you'll understand it in the next slides. So FDA approves the mission. Now from 2008 for the first approval till 2022, there are almost 8 companies approved by FDA. One is Mag Venture, the rightmost which we are using in Asha Hospital. This we recently purchased. This is the deep TMS, the BrainsWay deep TMS, which I'm talking about, the helmets. You can see 9 helmets there, 9 helmets, right? Each helmet is for disorder. H1, depression, H7, OCD, H4, nicotine. So there are different disorders, different numbers, okay? Max Team, Neurostar, Apollo TMS, Cloud TMS, then N number of companies. Approximately 8 companies were approved by FDA till now, okay? So TMS is safe, completely non-invasive, no surgery, no seizure, no anesthesia, no sedation, no cognitive deficits. In fact, TMS is approved for treatment of cognitive deficits. Now there is protocols for Alzheimer's, right? So there is no drug side effects, there is no need of admission. You can just walk in OP, take the session, 20 minutes, sit in the chair, go back to your work immediately. Daily activities and adherence is highest with TMS. We see in Asha Hospital, we do more than 30 to 40 sessions per day. And the discontinuation rate is less than 1 to 2%. All the 100 patients who receive TMS will be very happy with TMS. So adherence is very high. So when it comes to the parts of TMS, to make it simple, it has 2 parts. One is the main unit, the stimulator. The second one is the coil. The stimulator and coil are connected with a wire, that's it. Stimulator and a coil. Coil shapes differ, like the figure of 8 coil which I am showing is used for most of the disorders, okay? So, as I said, now the stimulator has 2 parts again, capacitor and thyristor. TMS has 2 parts, stimulator, coil, and the stimulator has 2 parts, capacitor and thyristor. Capacitor is, so for example, from the switchboard, the current is coming through a wire, and the current is stored in a capacitor inside the machine. And this capacitor transfers this current to a thyristor. Now, thyristor is a switch. It makes it on and off. As I said, we need on and off current. Continuous current will never create a magnetic field. So, thyristor will make the current on and off. Okay? So, from the thyristor, the stimulator, it is connected to wire and then the coil. In the coil, as I said, the primary current creating a magnetic field near to your brain creates a secondary current. So there are different shapes. So Anthony Barker first made a circular coil, okay? Circular coil. Next came the figure of 8 coil. I'll tell what is the difference between that. Figure of 8 coil. That is the helmet coil recently approved by FDA, the BrainsWay helmet. And this is a double cone coil. Double cone coil is nothing but figure of 8 coil. They made it in a curve for deep penetration. Okay? When the helmet and the double cone coil has deep penetration to your brain. I'll show in the next slide. So as I said, figure of 8 coil is the most commonly used coil. The penetration depth of the magnetic field is 2 centimeters. From here, 2 centimeters. And if it is a double cone coil, it is 4 to 5 centimeters. If it is a helmet, it is 6 centimeters. But why we need such a depth? To stimulate the deeper parts of our brain, like limbic system, basal ganglia, anterior cingulate, dorsomedial prefrontal cortex. Okay? So for OCD, especially for OCD, we need to stimulate the deeper parts of the brain. That's why the helmet and the double cone coil are used. It has a deep penetration. But most of the disorders in psychiatry for which the TMS is approved, we are using the figure of 8 coil. Okay? And as I said, it is producing a magnetic field, right? The magnetic field is very strong. It is approximately 1.5 to 2.5 Tesla. So, you know, it is equivalent to MRI machine. MRI machine is 3 Tesla. Okay? But here, you know the magnetic field of the Earth? Earth's magnetic field. It's 0.00005. So it is, the magnetic field of the TMS is 30,000 times more than the Earth's magnetic field. But this magnetic field is not continuous. As I said, it's only for a microsecond. The stimulus will be like this. Tick, 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 tick. Like if you go to if you have ever been into an MRI machine, you'll hear a sound. Tick, 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 tick. That is also a magnetic pulse. The same way the TMS machine. And this magnetic field, like if at all, this is the coil. 30 centimeters from the coil, the magnetic field is completely nullified. So it is not throughout the body. So it is 30 centimeters from the coil. The strong magnetic field is only 30 centimeters around the chin. So as I said, the coil shape, the circular coil and figure of 8, this is the difference. So circular coil was stimulating the periphery, so it lost the focus. Okay? Now they made 2 circular coils together. So the stimulus was in the center of the figure of 8. So it has more focus. That's why figure of 8 coil became more famous, and it was widely accepted, and it's used for most of the disorder because you can target. Now for example, I want to target DLPFC, I can target DLPFC. I want to target motor cortex, I can target motor cortex. I want to target occipital, I can target occipital. The focus is good with the figure of 8 coil. So you can see in this diagram, circular coil is stimulating the periphery, but the focus is lost. But figure of 8 coil, it's stimulating the exact focus. So mechanism, it changes the blood flow, it changes the neurotransmitters, it increases BDNF, it decreases CRH and ACTH, the stress hormones. So with TMS, you can inhibit the brain and also excite the brain. There's long-term potentiation, there's long-term depression. So it is not only like, for example, if I'm giving a stimulus here with the TMS machine, the stimulus after some time will pass from left brain to right brain, from the periphery to deeper. The stimulus shifts from one place to another place. So for example, if you see, if I'm stimulating here, after some time the stimulus has spread to the next part of the brain, the opposite side of the brain. And also it shifts from, if I'm stimulating in depression, I'm stimulating DLPFC. It's not only stimulating DLPFC. The brain is a circuit, right? There are different circuits, right? If you stimulate one part of the brain, the stimulus goes to different parts of the brain, okay? So here in this diagram, I'm stimulating the left DLPFC in depression, the frontal, anterior cingulate, the limbic structures, amygdala are also stimulated. So if you see this diagram, in depression, and there is no depression. I'll show you the next diagram. No TMS, after TMS. It's almost similar, right? Depression, no depression. No TMS, after TMS. It's almost like a non-depressive brain. So this is by fMRI. So when it comes to types of TMS, there is single pulse TMS, paid pulse TMS, repetitive TMS. The topic is only repetitive TMS. The single pulse, paid pulse are for research purpose. They give a pulse. For example, Anthony Barker, it is a single pulse TMS. He used to give single pulse on the motor cortex and used to see the movements of the hand and legs. So paid pulse, they give one stimulus here, they measure the differences. It's only for research purpose. Our topic is for therapeutic benefit, that is RTMS, that is a repetitive TMS, where you give continuous magnetic pulses. And as I said, theta burst is a pattern TMS. I'll explain it later. It's an express TMS. So as I said, TMS can excite your brain and inhibit the brain. But you might get a doubt. I'm stimulating the brain, but how can I inhibit it? Huh? Anyone? I'm giving a stimulation, but how can I inhibit the brain? Huh? Yeah, so the brain is made up of different types of neurons, like few are dopaminergic, glutamatergic, and GABAergic. Usually, it depends upon the frequency. So 1 hertz is that if I'm giving 1 pulse per second, it is usually inhibitory because it is stimulating the GABAergic neurons. Once the GABAergic neurons are stimulated, your brain shut down, right? So any frequency above 5 hertz is stimulatory. Okay? Number of pulses per second is frequency. If it is more than 5, you are exciting your brain. If it is 1, you are inhibiting the brain. That's it. But most of the protocols, excitatory 10 hertz, inhibitory 1 hertz. You remember just these two things, 10 hertz, 1 hertz. So as I said, number of pulses in a second is hertz, right? For example, in the top one every second, in 10 seconds there are 10 pulses. So the frequency is 1 hertz. And here in 1 second there are 5 pulses. So frequency is 5 hertz. Here in 1 second there are 10 pulses. It is 10 hertz. Most of the protocols in psychiatry is with excitation. If it is 10 hertz, if it is inhibitory, it is 1 hertz. So actual protocol looks like this. Okay, I'll explain it later. So as I said, you can excite the brain, you can inhibit the brain. 10 hertz for excitation, inhibition 1 hertz. And you should know a specific location. Each and every disorder has its location. For example, depression, left dorsolateral prefrontal cortex. OCD, dorsomedial prefrontal cortex. Hallucination, temporoparietal junction. Cognitive dysfunction, there are many areas for cognitive dysfunctions. Like negative symptoms of schizophrenia, left DLPFC. Okay? So you need to know the location where you want to give the stimulus. You should know whether you are inhibiting or exciting your brain. And you should find out the resting membrane potential, resting motor threshold. This is the minimal energy required to excite the brain. My RMT is different from your RMT is different from your friend's RMT. Okay? So for doing a therapy, you need to measure the RMT first. I'll explain how to measure it. And you should know how many pulses you are giving in the session and what is the frequency, either you are exciting it or inhibiting it. You should know where you are stimulating it. And group of pulses is called a train. Okay? Group of pulses is called a train. So in a protocol, you should know number of trains in the protocol, and the gap between a train is intertrain interval. You should know the intertrain interval. You should know the total time for the session and how many sessions you want to give him and for how many weeks you want to treat him. If you see the previous diagram, this is a train, the bottom one. Group of pulses is the train. Gap between trains is intertrain interval. Okay, so I'll discuss only one protocol because different disorders have different protocols. For depression, this is the protocol approved by FDA. You're stimulating, because depression, hyperactivity, you're stimulating it. So if you're stimulating it, it's 10 hertz. Where you're stimulating? Left DLPFC, left dorsolateral prefrontal cortex. And as I said, in this protocol, they said that it is 120% of the resting motor threshold. For example, my resting motor threshold is 50. In the protocol, you should set 60. It is 120% of 50. Okay? So 300 pulses, 75 trains, 40 trains in a pulse. See, 40 pulses in a train. Intertrain interval is 26 seconds. Total pulses is 3,000 pulses, 37.5 minutes. You treat them for at least 30 sessions, 6 weeks, 5 sessions in a week. They made it Monday to Friday because it's FDA, because Saturday and Sunday are a holiday in US. So in India, you can continue the sessions, okay? The whole logic is at least 20 to 30 sessions for a therapeutic response. The response you'll see from 10 sessions, but at least 15 to 20 sessions is good for depression. Each session is 37.5 minutes. And the most important thing now, you need to select the patient for whom TMS is useful. So depression it is approved, OCD it is approved, addictions it is approved, So you should not post every patient for TMS. You should first know a perfect diagnosis, and you should decide whether TMS is useful for him or not. Okay? And next, FDA has put an age limit for TMS, 22 to 70 years. But the next 1 year or so, it is approving for even for autism and also for Alzheimer's. Autism and Alzheimer's are already approved by Europe, CE. Only FDA approval is pending. So the age limit is not that important. And off-label uses, as I said, bipolar depression, Parkinson's, negative symptoms in schizophrenia, auditory hallucinations, addictions, PTSD, dementia, pain, everywhere. You can use TMS everywhere. And all this off-label are off-label for FDA. But now it is CE approved. All these are practiced in Europe. Okay? Even for pain, like for example, there's a good study. They took n number of patients who undergone gastric bypass surgery, and post-surgery, they gave an inhibitory protocol on the frontal lobes. And they saw that the use of morphine has decreased. Post-operatively, the use of morphine has decreased. So, once you decide you want to give TMS, later you should explain the patient what is TMS. So explain him the procedure, explain him the indications, explain him the risks, contraindication, and what will improve actually. Because if you give him 2 sessions of TMS, nothing will improve. So you should make it clear. Take 10 to 15 sessions. The response will be after 10 to 15. Between 10 to 15 sessions, you need to wait. It's a slow process. It's not like ECT. Immediately I give a session, you can't, the improvement is not visible. So this thing you should explain to the patient clearly. Okay? And you should show him the process of the TMS in a video. You should have a TMS booklet. And you should explain him the adverse events, right? Adverse effects of TMS. TMS is completely safe. Okay? It's 100% safe. But mild side effects like the first TMS session, it might create a mild scalp irritation, tension headache, or if the TMS coil, if you're moving towards front, it might stimulate your trigeminal nerve. So you might have muscle twitch, jaw pain. These are very less common, okay? And neck pain, transient hearing loss. So, as I said, TMS is giving a magnetic pulse. Tuck, 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 tuck. This is sound, right? So, though the sound is very low and only for a microsecond, FDA says that there is a chance of transient hearing loss, okay? So, as you go for MRI, they give you cotton buds, right? The same thing with TMS, they'll put ear plugs. So, usually our hearing range is between 0 to 180 decibels. The normal talk is 50 decibel. If you shout loudly, 70 decibel. If you are in a pub music, it's 90 decibel. Traffic, 100 decibel. Siren, ambulance siren, 120 decibel. Fireworks, 140 decibel. TMS gives 140 decibel sound. But it's not, if you see a TMS machine, you will not even identify the sound. Okay, it's like tuck, 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 tuck. I'll show you in the video. Okay, but it says that you should use ear plugs while giving a TMS session because the coil is very close to your ear. Okay, so but with these side effects, the discontinuation rate throughout the world is less than 3%. In Asia, it's less than 1%. Okay, and seizure, though it is very rare, it is because you're stimulating your brain, right? There's a chance of a seizure episode. So, but all the studies say that it's less than 0.1%. Okay, but usually seizure occurs. So now, for example, I'm stimulating the DLPFC. If I place the coil near the motor cortex and give high frequency stimulus, you may land up in seizure. Okay, it's very rare. So though it is very rare, we need to take all the precautions for seizure. Okay, so as I said, if the coil is located near the motor cortex and giving high frequency, seizure. Patient past history of seizures, family history of seizures, brain tumor, strokes, and head injury. These are not contraindicated. Brain tumor, stroke, head injury, you can give TMS. And also, you need to see whether the brain is excited. So if you are on Concerta, methylphenidate, high dose of methylphenidate, patient is very irritable, he's sleep deprived, his brain is excited, right? At that time, if you give TMS, there's chance of seizure. Okay? Okay? Alcohol withdrawal, excited brain. During alcohol withdrawal, if TMS, now it is approved by CE for addictions, but not during the withdrawal period. Post withdrawal, you need to give the TMS. So during withdrawal, brain is excited, give the TMS, chance of seizure. Sleep deprived, as I said. And also drugs. Drugs which reduce the seizure threshold. So before TMS, you should have the entire history of the patient. What drugs, what is going on, diagnosis, everything. So for example, clozapine, bupropion, tricyclics, lithium can reduce the seizure threshold, right? And there should be a trained technician, there should be a TMS seizure policy, but till now in ASHA, we never had a seizure episode, never had a seizure episode. So contraindications, anything which is contraindicated for MRI is contraindicated for TMS. But only thing is, it should be 30 centimeters from the coil. Okay? So if you have an implant in your leg, you can go ahead. Implant in your hand, go ahead. Okay? Now even implant in your head, you can go ahead. It should be MRI compatible. Titanium implants, not metallic implants. So brain electrodes, aneurysm clips, cochlear, dental implants, you need to be little bit careful, but you can go ahead. Only thing is cardiac pacemakers. So cardiac pacemakers, though it is away from the coil, the risk is, it is not only the magnetic attraction with the TMS. As I said, magnetic field is again producing an electric field, right? So it can dislodge the electric circuit, the parameters of your pacemaker. It can heat up the pacemaker. So it is not that safe, but now they are doing studies on patients with pacemakers also. But cardiac stents, 100% you can give. So there's anywhere, like even the aneurysm clip, if it is a titanium compatible, you can go ahead. So only 30 centimeters is a rule from the coil, there is no metal object. So before doing, as I identified the patient, I know the diagnosis, I have explained the patient, now I need to do a task scale, a screening scale. It is transcranial magnetic stimulation, adult safety screening. All the questions about the metals, EEG, seizure episode, family history of seizure, all the 15 questions, okay? You need to do a task scale. So after task scale, you take the consent. As ECT, even TMS needs a consent, for sure. You need to explain everything, screen it, and take the consent. And TMS room looks like this. A patient in the chair, a coil connected by a wire, and that's a stimulator. This is a mag venture which we are using in ASHA. That's the stimulator, wire, and a coil. It's just, you just sit in the chair. No, 20 minutes, you can go back. Okay? So what is important in TMS room? It should be spacious first. AC, because the coil is the machine will get heated up. And you require an ice pack, because the coil, as the current is going on for 20 minutes, it heats up. But the exterior of the coil will not heat up. Even if you touch, it is not warm. Inside, the copper wiring gets heated up. So you need to put an ice pack if you are doing continuous sessions. For example, if you are doing 20 sessions for 20 patients, you need to put an ice pack. And as I said, no metals, ferromagnetic substance, 30 centimeters rule. Same time, your earrings, spectacle, metals, chains, everything should be removed. And I'll tell you one thing. A technician, like he has done 20 sessions. He went to KFC. He ordered something, ate, and did a swipe with his card, and it was not working. Why? Because the magnetic field will even interact with the EMV chip, the microchip in your credit card. Okay? So you should remove all your phones, electronic watches, metal watches, keep it in the locker, even the technician and the patient. Okay? So as I said, you know the protocol, you know the patient, you know the location and everything. For example, for a depressive patient. Now first thing, as I said, you need to know the patient's RMT. Right? The resting motor threshold. So resting motor threshold is the minimum energy to stimulate the brain. How you identify it? So first, I take a measure from nascion to enion, approximately 36 centimeters. In the midpoint, take a line from tragus to tragus. The center point is CZ, right? The vertex. Nasion to enion, tragus to tragus. Intersection point is CZ. From the CZ, in this diagram, if you move 5 centimeters left, where we are going? In this diagram. 5 centimeters left from CZ. Huh? Which area of your brain? It's hand, right? Hand. So, and it is a large area. It is easy to stimulate. So, they identified that to identify resting motor threshold, this is the hotspot. So, nasion to enion, tragus to tragus, CZ. From CZ, you move 5 centimeters left is your motor hotspot to stimulate your right hand. So, if you give a stimulus there, your right hand, you can observe a twitch in the right hand. Okay? So, resting motor. So, for example, I am giving a stimulus at 40 for me. There is no twitch. I am giving it 45, no twitch. 50, I got a twitch. So, this 50 is my resting membrane motor threshold because it is able to stimulate your brain. What is the evidence? You are seeing the twitch in the right hand, in the abductor pollicis brevis, the right thumb. Okay? So, 5 centimeter rule. Nasion to enion, tragus to tragus, CZ, go left to 5 centimeters, you find your spot to stimulate your hand to find out the resting motor threshold. And you can find out in EEG also. CZ, 5 centimeters, you have C3 marking in EEG. If you wear a EEG cap, the C3 is your motor hotspot. So neuronavigation is a complete different procedure. They take an MRI and directly you can find a hotspot in the computer. Okay? So, as I said, few protocols will stimulate hand. Most of the, 90% of the protocols. Resting motor threshold is finding with the hotspot for the hand. For few protocols like OCD, I'll explain it later why, you need to find out the place for your leg, to stimulate your leg. So if you see the motor cortex from the top, the motor cortex is not like straight like this. It is a curve towards the back side. So from CZ, if you go 2 centimeters back, what you'll stimulate? Your leg. If you see in the diagram, the cortex is towards the back side. From CZ, I'm going 2 centimeters back. You'll stimulate your leg. From CZ, if I go 5 centimeters left, you'll stimulate your hand. Okay? So you just forget this. This is not that important. Stimulation of the leg. Most of the protocols are with the hand. You remember nasion to enion, tragus to tragus, CZ, left 5 centimeters, hand stimulation. So RMT, as I said, it varies from person to person. So in the mission, you put the amplitude at 50 and try once. If it is there, you give 5 seconds gap and try again. If you're swinging the twitch, give 5 seconds gap, try again. So you should get at least, if you give 10 stimulus, at least 5. So that is your resting motor threshold. If it is exaggerated response, you reduce the amplitude and try again. If there is no response, you increase the amplitude and try again. But most of the patients, the resting motor threshold will be between 40 to 50 for sure. Okay? So in the protocol, as I said, depression, stimulatory, 10 hertz, left DLPFC, 75 trains, 40 pulses per train, intertrain interval 26 seconds, total session 37.5 minutes, 5 sessions a week, total 30 sessions. But I first said in the mission you should make the amplitude, now my amplitude is, my threshold is 50. I saw the twitch at 50. In the mission we should make it 120% of 50. You should put it at 60 and start the protocol. Okay? So as I said, RMT varies, coil positioning, brain size, this is not that important. But as I said, EEG mission, EEG system, is CZ is the center point, C3 is the motor hotspot, and if you go 5 centimeters anterior, you go 5 centimeters up from C3 is F3, that is the left DLPFC. That is the target spot for depression now. Okay? So for hallucinations between P3 and T3, the TP3 line, the temporoparietal junction, you're inhibiting there. Okay? So just remember CZ, C3 is a motor hotspot, F3 is your dorsolateral prefrontal cortex. We are only talking about depression. Okay? So Now, I know the RMT, I have set the mission at 120%, I have given a depression protocol, one session is done. So as I said, minimum 10 to 15 sessions, each session, each day, 1 or 2 sessions, complete 15 sessions, you'll find a therapeutic response, you can measure it in the scale, right? You do a BDI before the TMS session, and after completing 5 to 6 sessions, again do a BDI, the score will reduce, okay? So like that, like medications, when we are stopping, while stopping TMS, we give it tapering phase, okay? Like the last, after completing 20 to 25 sessions, next week you give 3 sessions, next week you give 2 sessions, next week you give 1 session and stop. And also TMS is approved for maintenance TMS. Like the patient comes every month, take 2 sessions and go. So as I said, a quick recall, the whole theory is current magnet current. You need a diagnosis, you need to give complete information, you need to screen, you need to take the consent, you need to know about the risk of seizure, you need to know the drugs, how the TMS room is maintained. First you take the hotspot, you take the RMT, increase the RMT by 120%, set the protocol, that's done. So special scenarios like perinatal depression, TMS you can give in pregnancy also. The fundus is away 30 centimeters from, anything away 30 centimeters from, you can do it, okay? So, but measure the risk, whether it is useful for that lady or not. Especially, give a brief session, not the complete 37 minutes, give a brief session for 15 minutes for perinatal depression. So, I have given a 30-minute session for a lady, a pregnant lady, and she, post-session, she complained of nausea, dizziness, palpitation, and sweating. What it might be. So it is supine hypotension. You need to take care of this because the weight of the baby is falling on the inferior vena cava, right? As you saw in the TMS room, she's sleeping on the chair. So then the baby's weight is on the inferior vena cava. So you should, while doing a TMS session, it is better to put a pillow on behind the right hip so that there will be tilt. The weight will be transferred towards the left. Inferior vena cava is on the right side, right? So this is the precaution you need to take while giving TMS for pregnant ladies. So newer things in TMS, as I said, theta burst. The original protocol was for 37.5 minutes, right? Now theta burst is for 3 minutes. So theta burst is nothing different. Here also there are trains. Here also group of pulses is called a train, intertrain interval. Everything is same. But only the time period is 3 minutes because this is given as a burst. Each burst has 3 pulses. For example, in theta burst, if I am giving 10 bursts, so you are delivering 30 pulses. Each burst has 3 pulses. Okay, if I am giving 20 bursts, you are delivering 60 pulses. So the time period is reduced. So now this is also approved for FDA, approved for depression. TMS, 3 minutes, go home. So TMS and psychotherapy, they say that while giving TMS session, don't keep the patient idle because there is no sedation, there is nothing, the patient is in a chair, you are there, try to talk, make the brain active. At the same time, TMS is now done along with psychotherapy. Like while doing the TMS session, a counselor will be sitting and doing cognitive behavioral therapy. Before the TMS session, you can do CBT. After the TMS session, you can do CBT. Study says that TMS along with TMS with psychotherapy is more beneficial than TMS alone. Okay? So while doing TMS, you can do n number of things. You can talk, you can ask the patient to write the thought diary, you can talk about the negative cognitions, you can do ERP, you can do CBT, you can teach them breathing exercises, make them comfortable, put some music, put some comedy show, give them a cognitive task. Even now they are giving iPads. In the iPad, there is cognitive behavioral therapy. There are apps, eCouch. The patient will be doing a cognitive task and TMS is going on. And befriending, that's what. So you know what is befriending? No, befriending is getting popular in UK and US now. Like, for example, for depression and Alzheimer's, you can book a person. An NGO will come to your house, will stay from morning to night. He'll be with you, he'll come with you, he's a companion, befriending. So TMS is like the technician should be as a friend, okay? So the next advance is neuronavigation. As I said, to locate the hotspot or locate the DLPFC, there are 5 centimeter rule. 5 centimeter you're coming here, 5 centimeter you're going anterior, you got the DLPFC, right? In EEG cap, C3 is your hotspot, F3 is your DLPFC. But now, neuronavigation. Take an MRI, put it in the computer, computer will tell you where is the hotspot, where is the DLPFC. Okay? More accurate. NeuroAD, this is the next advancement. This is for Alzheimer's disease. This is a separate machine. This session is for 1 hour. You stimulate Broca's, Wernicke's, somatosensory, DLPFC, along with the cognitive task. The person will be doing a cognitive task and the TMS is given. And robotic arm. Now, I took Nasion to Enion, tragus to tragus, identified, measure, everything is done, right? But I place the coil. But during the session, if the patient moves the head, everything is lost. But usually, we keep a cap. There's a TMS cap, a white cap. First you fix it and make the measurements on the cap. So even if he moves, again you know where is the hotspot, where is the DLPFC. So robotic arm, once you set the TMS for the DLPFC, even I'm moving here, the coil will also move. If I'm moving here, the coil will move along with your head. So robotic arm. So TMS and neuro, as I said, you should be careful while stroke. But now TMS is approved for stroke. As I said, seizure is the worst complication. Now TMS is approved for seizure. Okay, I'll tell in the next slide. For stroke, so if you stimulate the affected part, stimulation, high frequency. What is high frequency? 10 hertz, right? 10 hertz stimulation at here, and the machine will raise your hand. Neuro rehabilitation. You're linking the stimulus with the physical activity to improve your strength of your arm. So now you have a left infarct, you have right paralysis, right? Right weakness. So stimulus, machine will lift your hand. Stimulus, machine will lift your hand. TMS, this is heights of technology. TMS with virtual reality. So this is for phobias, PTSD, OCD, exposure response, anything. They'll show you, like for example, I have a phobia of snakes. In the VR, you will be seeing snakes, and they'll give you the stimulus. Even for Alzheimer's and dementia, now there's a VR. They will give a cognitive task to open the door, take the water bottle from the fridge. So in the VR, you will be moving, and TMS will be running. So this is for PGs. Left DLPFC, 120% of RMT, 20 trains, intertrain interval is 30 seconds, 60 pulses per train. So what are the total number of pulses? Huh? How much? Huh? Huh? I don't know. So 60 pulses per train, right? There are 20 trains, 1200. Left DLPFC, 100% RMT, 10 hertz, 20 trains, 30 pulses per train. What is the total time for a session? So total number of pulses here, 600, right? 10 hertz means 1 second you're giving 10 pulses. So you need to deliver 600 pulses. How much? 60 seconds. So theta burst. Now 30 bursts per train, 20 trains, 5 hertz, left DLPFC. Total number of pulses. Huh? No. Now 30 bursts, 20 trains, right? How many total bursts? 600, right? Each burst, how many pulses? 3, 1800. So, is it very important to remember the protocols? Because everywhere there is a protocol. Depression, OCD. So, it's not that important because the machine already has the protocol. But you should know the basics of the protocol. As I said, pulse, group of pulses is train, gap within a train is intertrain interval, the total time period for the session, how many pulses you are delivering, and what is the frequency you are setting in the machine. If it is 1 hertz, you're inhibiting the brain. If it is 10 hertz, you're stimulating the brain. Okay? So for depression, as I said, 75 trains, 40 trains, different. For example, for OCD, there's one more protocol. So here, see, it is bilateral. For depression, we are giving a DLPFC, right? For OCD, you should give a dorsomedial prefrontal cortex. That is why we are measuring the leg motor threshold. For most of the disorders, we measure the hotspot for the hand. For OCD, we take the hotspot for the leg. Why? Because the leg, see here, if you see C3, hotspot for hand, right? It is easy for me to go anterior 5 centimeters and stimulate the DLPFC. But dorsomedial prefrontal cortex is somewhere in the midline, interior, deep. So that's why I need to stimulate the leg. If you see the homunculus of the motor cortex, the leg will be deep inside, if you see the diagram. So I'm making sure that the stimulus is stimulating my leg. So for definitely it will stimulate the DMPFC also, dorsomedial prefrontal cortex also. So I'll locate the leg motor hotspot and go 4 centimeters anterior. You will find your dorsomedial prefrontal cortex for OCD. So addictions, there's a protocol. So to make it simple, as I said, 1 hertz you inhibit, 10 hertz is stimulatory. Depression, left DLPFC. OCD, dorsomedial prefrontal cortex. Nicotine, left DLPFC. Alcohol, right DLPFC. Hallucination, temporoparietal junction. Hallucinations, the brain is excited, I need to inhibit. How much? 1 hertz. Negative symptoms, the brain is deactivated there. Negative symptoms like depression, I need to stimulate. I give 10 hertz on DLPFC, left DLPFC. Bipolar depression, now this is a good thing. CE has approved for bipolar depression also. So now, as I said, I'm stimulating the left DLPFC for depression, right? The logic in TMS is if you stimulate the left DLPFC, you're inhibiting your right side. If you are inhibiting your left side, you're stimulating your right side. That's a brain function. Okay? Stimulate one side, inhibit the other side. If you inhibit the other side, you'll stimulate the other side. So now, if I give, for a bipolar depression patient, I'm giving a high frequency 10 hertz stimulus on the left DLPFC. What might happen? The chance of switch is more, right? He might switch into mania because I'm stimulating the brain more. So that's why I'll try to inhibit the opposite side. Bipolar depression, I'll inhibit the opposite side of the brain. I'll inhibit the right DLPFC. It is safer. And also he should be on some anticonvulsant and probably not on an antidepressant for at least 2 weeks. That is the approval given by UK. So these are everything. As I said, seizure. Now, as I said, seizure is a side effect. Now, it is approved for seizure also. So what you do, seizure is hyperactivity, right? You give an inhibitory protocol, where you give motor cortex. The motor cortex, you give an inhibitory protocol for seizures. So apart from all these things, it is very important with whom you are giving. Diagnose the patient perfectly, screen the patient, explain to the patient. The therapist should know the procedure. You should know the location where you are giving. You should know the protocol. You should know the procedure. You should know how many sessions you give. As I said, at least 10 to 15 sessions. Give 5 sessions, there is no benefit at all. Okay? If the patient says, I want only 5 sessions, don't do TMS. Okay? So is TMS too costly? The cost of the TMS session is much less than the cost of the disease, right? So TMS sessions, it's costing around 1,500 to 2,000, 2,500, one session. But it's very much less than the cost of depression, right? So we had drugs, we had ECT. ECT is wonderful. We had ECT, we have psychotherapy, and for sure, TMS is the future 4th wave in psychiatry. So Dr. Prasad Rao sir, he is one of our directors. He has done extensive research on TMS. It is a very good article. You can have a look of TMS. And this is my certificate. This is where I started studying TMS. AIMS, hands-on workshop. If at all you get an opportunity, please go. It's a wonderful workshop for 3 days. Wonderful. You get hands-on experience. And if Chandrasekhar sir accepts, we can also have a workshop at Asha Hospital. You can have a hands-on experience. So as I said, this is our TMS room, Asha. This is the figure of 8 coil which we are using for all the disorders, A to Z. Depression, OCD, everything. This is recently approved by FDA, double cone coil. This is the MagVenture machine which we are using, stimulator, connector, and a coil. This is me with my TMS expert Venkatramana. This is just simple, attaching the stand, but you should have a core knowledge of TMS. It is very simple to give. If you learn now, you can give tomorrow. So this is, as I said, neuronavigation. We just purchased neuronavigation. It is in the transit. It is about to come to Asha. The neuronavigation, MRI guided. And what is this? As I said, the deep TMS, BrainsWay, helmets. We recently purchased this. This is approved for OCD, nicotine, depression. And about to get approval for autism, Alzheimer's, bipolar depression, auditory hallucination, negative symptoms of schizophrenia in the next 1 year. It got already approved in UK. FDA approval is pending. So, thank you so much. So, the strongest magnet in this world is in Florida. So, 45 Tesla. Okay. So, as I couldn't bring the TMS machine here, I'll show a video. Okay, it's just a short video of 10 minutes. So, as I said, C3, F3, DLPFC, left DLPFC protocol. Hi everyone, I'm Dr. Sandeep Kondepi. I'm a consultant psychiatrist at Asha Hospital, Banjara Hills, and also part of Asha Neuromodulation Society. So at Asha, we have already completed 10 years of our journey in neuromodulation. So apart from ECT, we perform TDCS and TMS. So at Asha, on OP and also on inpatient basis, we do approximately 30 to 40 sessions of TMS per day. So he is Venkatramana. He is a part of Asha Neuromodulation Society and a TMS expert. So when it comes to TMS session, first we identify the patient, we confirm the diagnosis, and if at all we feel that TMS will be useful for the patient, we explain the in detail procedure, its indications and complications. Later on, we do a TAS scale, which is a transcranial magnetic stimulation adult safety screening scale. After doing the screening process, we take the consent and we go ahead with the procedure. So TMS machine has two parts. One is the main unit, this is the stimulator. And the second one is the coil. The coil is connected to the stimulator. So this is a figure of 8 coil. Okay. So coil, we have two types of coil. One is the most commonly used coil is the figure of 8 coil. Including depression, we use it for addictions, negative symptoms of schizophrenia, cognitive dysfunctions, and auditory hallucinations in schizophrenia. So we have one more coil which was recently approved by FDA for OCD. This is a double cone coil. So the only difference is there is a curve, 15 degrees curve from the right and left for deep penetration. This is used for especially for OCD. Once we confirm the diagnosis, screen him and take the consent, before starting the TMS procedure, we ask the patient to remove all his metal ornaments and electronic devices. And even the technician or the doctor who is in the TMS room should remove his phone or smartwatches and all the electronic devices. This is called the TMS cap. This cap is useful to mark the measurement. So as I said, we can't mark it on the head. You use one cap for one patient. Every time there is no need to measure, right? You take the CZ, C3 marking and F3 marking. Every time you place the cap and start the session. To identify the motor hotspot. So we put on this cap onto the patient and also start doing the measurement. The first measurement, as I said, we take the measurement from nascian to enion and also from the tragus to tragus. The intersection point of these two lines is, the center point is CZ. after identifying CZ, if we move 5 centimeters towards the left, we get the motor hotspot. So in the motor cortex, if we move from vertex to 5 centimeters to the left, you will find the motor cortex for your right hand. As I'm identifying the left motor cortex, you can stimulate the right hand. So this point is C3. It is 5 centimeters from CZ. So this is called the motor hotspot. So C3 is helpful for identifying the F3 also. Once you identify C3, you go just straight 5 centimeters is the DLPFC. And also C3 is a point where you measure the RMT. There are two uses identifying C3. Okay, where you give the stimulus. After identifying the motor hotspot, which is 5 centimeters left to the CZ, so we start giving stimulus here with the coil. So once we give the stimulus, we need to identify twitching in the right thumb. So as we are stimulating the left motor cortex, we need to see for muscle twitches in the right hand or right thumb. Once we identified the motor hotspot, the next thing is that we should identify the patient's motor threshold. So this is the machine, this is the stimulator, and this is the screen. So first we should enable the coil. It will be in a disabled mode. Later on we should enable it, and you can see amplitude is 0% here. So now first we'll start with 40% amplitude. We start book says that you should start with 50, but it's better starting at the lowest one, right? 40. Giving the stimulus at 40% amplitude on the left motor hotspot to identify twitch on the right thumb. So if at all you are not finding a muscle twitch in the right thumb, we start increasing the amplitude by 2 points or 5 points, and we will try it again. So as I said, after setting the amplitude at 40%, now this is the figure of 8 coil. The center of the coil should touch the motor hotspot. So there is a button. If you see in the coil, there is a button. If you push the button, it will give one pulse or one stimulus. So during the motor threshold, while measuring, we are not giving the continuous TMS. It's not a continuous TMS. You should give only one pulse. So there's a special button near the coil. Only just give one click. So if you give a continuous pulse at C3, he'll land up in seizure because you're stimulating the motor cortex. Identify the hotspot and set the amplitude at 40. We will place the coil over the motor hotspot, that is C3, and start giving the pulses and identify the muscle twitch in the right thumb. So this is how, while stimulating the left motor cortex, so you're exactly stimulating your right abductor pollicis brevis. On the hotspot, you can find the muscle twitches in the right hand, especially in the right thumb. Once we identified the motor hotspot and also the motor threshold, now I am explaining about depression protocol. So in depression protocol, we need to identify the left dorsolateral prefrontal cortex, that is the left DLPFC. So the left DLPFC location is 5 centimeters anterior to the motor hotspot. So it is called 5 centimeter rule. From CZ to C3 is 5 centimeters, and from C3 to locate the left dorsolateral prefrontal cortex, it is again anteriorly you go 5 centimeters. This is F3 position, which is the left DLPFC. So this is a spot where you give the complete depression protocol. So to identify the motor threshold, it is C3. For the treatment procedure for depression, it is F3, which is 5 centimeters anterior from C3. So once the left DLPFC is identified, that is 5 centimeters anterior to C3, which is F3, we lock the coil to a stand. We put the coil in a stand and we place the center of the coil on this spot which we identified, that is the F3. So once we place the coil on F3, It is as simple as it is. We have to set the depression protocol in the main unit and start the procedure. So this is the coil and this has a stand. So this coil is fixed to the stand and is placed on the left DL PFC on F3. After placing the coil on the specific target, for example, here it is for depression. So after placing the coil on the left DL PFC, that is F3, the next point is, this is the main button in the stimulator. You will enable the coil. So once you enable the coil, it changes from red color to green color. And as I also said, for this patient, it was motor threshold we tested at 40, and if you see the depression protocol approved by FDA, it is 120% of the motor threshold. So if the motor threshold of a patient is 40%, so 120% is 48%. So you need to set the amplitude first at 48%. So it is 120%. There I gave an example of 50-60, the same thing. Of the motor threshold. In the stimulator, this is the part where you set the protocol. First, timing control should be in sequence, and next is repetition rate. So repetition rate is nothing but the frequency. For depression, what is the frequency? 10 hertz. Right?
Repetition rate is nothing but the frequency. So as in depression we are giving a stimulatory protocol, we have to set the frequency at 10 hertz. So it is 10 pulses per second. We have set it at 10 hertz. Next is pulses per train. So in the depression protocol approved by FDA, it is 40 pulses. So we will set the pulses per train at 40. And next is number of trains. It is 75 trains. So we will set it at 75 trains. Next, after setting the number of trains, we go to the intertrain interval, the space, the time gap between each train. So in depression protocol, it is 28 seconds.
There I told it as 26, here it is 28. Both are approved, 26, 28, 11.
Seconds, 28 seconds. So this is the exact protocol for depression approved by FDA. It is 10 hertz, 40 pulses per train, 75 trains, and the intertrain interval is 28 seconds. So the entire process will take around 37.5 minutes, and we are delivering 3000 pulses per session. So after setting the amplitude at 48, enabling the coil, setting the protocol, now it is just a single button, push the start, and the treatment starts. So once after taking the measurements, identifying the motor hotspot and also the left DLPFC, setting the protocol, once we push the start button, this is how it looks. It gives a pulsating sensation over the head, and it gives a call. Once we push the start button, this is how it looks.
How many pulses are delivered now? So one train. You have set 40 pulses per train, right? It delivered 40 pulses now. Now it is giving an intertrain gap. How much? We have set 28 seconds, so it will give a gap for 28 seconds. Again, tuck, 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 tuck.
Gives a pulsating sensation over the head, and it gives a sound like this. These are the magnetic pulses. Now this is the intertrain gap. There is no sound here and there are no pulses delivered. Once the intertrain gap is done, the next train starts. So after setting the protocol in the stimulator, 40 pulses in a train. Once it delivered 40 pulses in a train, it gives a intertrain interval. As I said, in depression protocol, the intertrain interval is 28 seconds, but for demonstration purpose, I have set it for 15 seconds. So after 15 seconds, again the train has started. So this train again has 40 pulses.
So while it is giving the pulses, the patient cannot feel anything. Just a sound, tuck, 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 tuck. So, sir, thank you so much.
So I think I was right. Nobody went to sleep. Thank you, Dr. Sandeep. I think it is really, I think, lot of insights I think we could get from today. Before, first we'll give the opportunity to the postgraduates to ask questions, then the consultants.
Can we give like more than one session per day?
So there is an accelerated protocol which is getting approved for acute suicidal ideation. It is 3 sessions per day for 5 days, 15 sessions for suicidal ideation.
So whether will that have any effect on the effectivity?
The minimum gap between the 2 sessions should be more than 30 minutes. That's it.
The effectivity will be same, sir?
Same.
Thank you.
Yeah.
Some more? Yeah. Doctor there.
Sir, the RTMS machine is an expensive machine, right?
Yes.
So, is there, knowing the mechanism of that machine and knowing that we already have MRI machines in our hospitals, do you think it's any way to like modify the existing setup to have?
I didn't understand. You mean to say you will modify the MRI machine to an RTMS machine?
I mean, theoretically, is that possible?
No.
No. Thank you, sir.
This has some different mechanism, right? There you are doing an imaging. Here it is, though the magnetic pulses are same, but this has a complete different mechanism. You need to locate the coil, the stimulator is different. Now the TMS machine now the cost starting from 25 lakhs, the basic FDA approved machine, and lasting up to 1.5 crore. Yeah,
so you're looking at the future investment also. Nice.
But the sessions cost is okay. It's 1,500 to 2,500.
Yeah.
The machine is costly.
Some more? Dr. Rufus is there.
Sir.
Dr. Rufus, you are not a PG anyway, but I give you a chance. Go ahead, please.
Yeah, congrats Sandeep for the nice presentation.
Thank you, sir.
And we both of us are contemporaries during our PG time. We both passed at the same time, did our practical at the same center also, sir. And I just want to say that I too had a hands-on experience at NIMHANS on RTMS. And really the lecture was very refreshing for me also, because I too had it long back and it was very refreshing for me. So thank you so much.
Thank you.
And I need, all the PGs should go for that hands-on training program, whenever they get a chance.
Yes sir. As rightly said, hands-on training, you can use the mission and you'll be more confident.
Yeah, you'll be using the coil, handheld coil and everything, and you'll get a very good experience. You'll feel that. Then only you'll never forget it in your life. Thank you.
Yeah, thank you, sir.
So more than even equal to that, we see now all the youngsters more into gadgets, more into tech savvy. Now, once upon a time there was nothing. You only know some tablet or somebody used to do some therapy, something like that. But now, as at least you're getting better intervention options, I think we should really explore. So then at least you are able to really able to get the better hands-on experience, and might be it is more patient friendly. Yes, some more.
One question, sir. Like, what do we instruct a patient of OCD, especially those with obsessive thoughts? Like, whether we instruct them to stimulate their obsessions during the procedure, or like we should just tell them to...
No, it's always better the technician or the doctor speaks with the patient and make them confident. Tell them to make a hierarchy of their obsessions, which is the toughest one, which is easy. You can discuss anything. They can write a thought diary, everything. What is the distress? You can ask them the history. It's always better to talk to the patient. Either you are giving an inhibitory protocol, stimulatory protocol, is irrespective of that. You just talk to the patient. See, any procedure, while doing the procedure, if you talk to the patient, they'll feel more comfortable. Right.
Very clear presentation. Lot of clarity has come to me. Which aspects of autism and Alzheimer's improve with the treatment?
So, just I read few articles, sir. Like still there are only in research phase. You're asking about FUS, no, sir? Focused ultrasound. No, about TMS.
About RTMS.
TMS is a stimulatory protocol on the left DLPFC, right DLPFC, Wernicke's and Broca's, sir. They give sessions consecutively on the 4 areas, but currently approved is left DLPFC and right DLPFC. The point to improve is the clarity of thought and also executive functions. Executive functions were improving in Alzheimer's.
Right. And in autism?
Autism is the communication was improving. They were because in autism they were stimulating the prefrontal cortex, the area where there are mirror neurons. Mirror neurons are for the communication. So they were in better understanding with the parents and they were used to communicate their emotions in autism.
So it is interesting, if the executive functions improve, then actually a lot of this ADHD, adult ADHD, and some of our schizophrenic patients also, they have more of executive function loss rather than cognitive function loss.
Yes.
So it will be a big game changer actually.
Yes, sir. So ADHD protocol is also in the last stages, sir. Like it is about to get approval. I feel in the next 2-3 years, almost 10 to 20 protocols will be approved by FDA.
Nice.
Okay.
But currently in Europe, sir, they're practicing, they're doing TMS for autism.
Right, okay.
Yes, doctor here.
Okay.
So how does it differ in the efficacy with and without pharmacotherapy?
That's what TMS has been experimented as a monotherapy also. The first TMS identified was like monotherapy only. They compared with sham TMS. Whoever were treatment resistant depression, they fed up with all the tablets and they want some treatment. TMS was tried and it was successful in treating treatment resistant. At the same time, it was successful for OCD also. So few of our patients, like if they're very aggressive or very psychotic sort of behavioral changes, and then we suggest them use tablets and TMS. TMS is like an adjuvant, and at the same time it can also be used as a monotherapy. And the patient says, I don't want any pharmacotherapy, then we can try 20 to 25 sessions of OCD, the OCD protocol with the OCD coil. See, the only thing is the response comes when you correctly place the coil, find the location, do the correct protocol, correct timing, then it will be for sure, it will show the response. Yeah.
So it looks like more experience, then we can perform the procedure better.
Yes, sir. Yes, sir.
Yeah, one more.
See, what is the protocol adopted for acute suicidal ideation? Is it inhibitory or excitatory?
Sir?
Suicidal ideation.
Alternate, sir. One session inhibitory, one session stimulatory. Stimulatory and inhibitory, alternate. It's not approved, but still about to get.
So, Dr. Sandeep, many times, psychiatric indications are depression, might be auditory hallucination, OCD, sometimes anxiety. But there are even non-psychiatric conditions also, like some chronic pains, might be in some movement disorders. In your experience, like any kind of acute conditions you try to deal, particularly in a patient with, let's say, OCD, is agitated, very anxious. Do you try this procedure also?
Very agitated or anxious is not.
I mean to say, it's not destructive. He's not, going to do some kind of destructive thing there.
But patient understands the thing, and if he gives consent, we can try. But if he moves his head and if he's little bit restless, it's not useful. It's better for patients who are calm and.
So do you try giving some mild dose of anxiolytics before the procedure, and does it work better? Nothing like that. Right.
If you give an anxiolytic, only thing is that your resting motor threshold will increase because anxiolytic will decrease the excitability of your brain. So the RMT, if I'm now on anxiolytics, my RMT from 50 might move to 55.
So even then we need to withhold the
No, sir.
medicines before?
We can give any time from 50, 60, 70, any time. But most of them will have an RMT between 40 to 50.
40.
All the patients.
Nice, yeah. Some more?
Sir?
One thing, sir, actually, once the patient takes TMS, the patient will like TMS, sir. He will come, I need the session, it's better. Even the immediate effects. Like for example, in depression, after taking the session, he feels that something is good, something I'm feeling better, I'm having a proper sleep today. See, the mood will not improve initially. The somatic symptoms improve. He says, I'm eating well, I'm thinking better. He'll feel that quality of improvement, like satisfactory from the patient. So usually the discontinuation rate is very less, sir. They will like TMS and they'll ask for TMS.
Right.
And comparatively, it's completely non-invasive. It's just the patient sitting in the chair, and so it is very comfortable for the patient also.
Is it helpful in case of treatment-resistant schizophrenia, sir?
No, that's what. In schizophrenia, there are many domains, right? In schizophrenia, you can improve hallucinations and you can improve negative functions. You cannot treat schizophrenia. Okay? So now negative symptoms of schizophrenia you can improve. Hallucinations you can decrease. We have tried, sir, in schizophrenia, the temporal lobe inhibition. There was a small girl, 16 years old. She tried ECT, she tried everything. She had persistent hallucinations. But 20 sessions of TMS, 1 Hertz temporoparietal junction, she's very happy now.
Very nice. Nice.
That's what I'm saying. TMS room is very comfortable. There's music, there is TV, there's an iPad. The kid will be playing the game. He'll be eating his ice cream. He can take the TMS.
Sir, is it possible for someone who's undergoing RTMS for depression to completely go off of their antidepressants, like totally? Treatment-resistant depression,
We'll not advise them, but as I said, it can be used as a monotherapy also. If the patient doesn't want to use pharmacotherapy, he can go for the TMS continuously and also take the maintenance TMS. So every 2 months I'll call him and give 2 sessions and he'll go back home. We can try, but it is not advisable.
Thank you.
Yes. Dr. Der.
Hello, sir. I want to know about any relapse rates of after TMS.
So response rate is 60 to 70%, and remission, most of the studies is more than remission will be for more than 4 months starting to 1 year, which is almost similar to our medications also. Right? Remission for more than 4 months, and even patients were without a lapse or without a relapse for more than 1 year. If at all they have the second episode, they'll again will start the sessions from starting, from 20 sessions again. But 60 to 70% of the people respond. But the only thing is you should do the protocol in a right way. So if here is the DLPFC, I locate here and give the protocol, it's nothing. And if the patient is not fitting for TMS, like not depression, not OCD, I'm bringing one intellectual disability, giving TMS, it's not working. So the diagnosis, the selection of the patient, the protocol is very, very important. And you should know what you are treating. For example, as you asked for schizophrenia, if I say TMS cures schizophrenia, I will reduce schizophrenia, the patient attendance will come back, right? Only thing you should be specific what is you are treating and explain them. Now the auditory hallucinations will come down, this is a better way and we are trying it, then you can.
Can I request Dr. Chandrasekhar sir to give his experience so that we all learn?
I think it was a lucid presentation, but just a couple of points more. One thing is I would like to stress that one need not have any doubts about the efficacy of the treatment modality, number one. as he already pointed out, the selection of the case, the appropriate protocol is a very important issue. And once you keep these two things properly in place, the satisfaction rate is extremely high in the patients and the relatives. I'll give you just two examples. One of my patients who had severe OCD, not responding to most of the drugs, had to be on a very high dose of several drugs, was not willing gradually because of various side effects of the drugs. A proper protocol and 30 sessions of OCD, remarkable improvement was there, and she went back. She doesn't stay in Hyderabad. After a year and a half, she had a relapse. Immediately she came back and said, start RTMS now. I will take some medicines for my sleep and other things, but please start RTMS immediately. Took the RTMS and went back saying that she is 75% better. Now she can manage with her OCD. That is one example. Probably there are several patients like that. The second example with reference to auditory hallucination schizophrenia. There were two patients in the same family, relatives. So one patient had refractory, both of them had hallucinations, but I don't know. One patient I put her on RTMS. There was significant reduction in the frequency and the intensity of the hallucinations, and they went back. I forgot about that. After a few months, the other relative came back and said, why didn't you recommend us this treatment to our daughter? Because I went to their house, I found her almost totally normal. Previously she used to mutter so many things and do that. Why didn't you recommend to her? I said, I'm sorry, then you bring her also, we'll give it. I mean, this shows that, it is the patient's own versions, not we trying to see the improvement. But I think if properly planned and executed, the treatment modality is a good modality. My personal feeling is that in the next probably a decade or a couple of decades, the neuromodulation techniques are going to rule over most of the treatment procedures in psychiatry. That is for certain. Because their modulation is the key word, I think. The way the drugs act for some time, and in some cases we need a maintenance sort of a medication where the neuromodulatory mechanisms come into play, same technique is being applied here. How long it lasts, what is modulated is probably still under investigation. For some it may be 3 months, for some it may be a year. Like say, some patients we treat for 3 months or 6 months with antidepressants. They don't relapse for 2 years. Whereas someone relapses within 6 months, we don't know the reason. Of course, there are several other etiological factors, but similarly here, some patient who has taken RTMS may relapse after 6 months, someone may not relapse for 2 years. As a single modality of treatment, probably not very well tried because of our own insecurity. I don't know whether this alone is going to help my patient, but it is worth trying in future, I think. Thank you.
Dr. Sanjay?
Actually, today it was a learning experience for me too, because I don't have much experience on this aspect. If I do get a chance to have a hands-on training, I would like to go for it and take it. And
sure, sir.
RTMS would be one thing I think sir has suggested, so much patient satisfaction, that is what we want if it is giving. Only catch is the investment point, otherwise it's a very good modality of treatment.
Sure,
Thank you.
I think that is really encouraging for you, Sandeep. I think we should start one program workshop at Asha Hospital,
Sure,
hands-on
sir.
experience, and it might encourage many more juniors and seniors. If there are no more questions...
One suggestion.
Yes, sir.
See, this is a very wonderful treatment, but as Sanjay says, a costly affair. So each psychiatrist need not think about having this, but we should develop a center which includes all neuromodulation techniques. Not just RTMS, but more and more techniques are going to come now. A single center can serve the total state, or 1, 2, 3 centers. Each individual psychiatrist need not plan, it's not worth. But one or two centers in the state having all types of neuromodulations together, which can also increase the research output and all those things. That should be planned.
Yes, sir.
When you have to try to upgrade your setup.
Yes.
Anyway,
whatever the new things come, just try to incorporate it.
Anyway, like once we had the CT mission at CDR hospitals long back, and it was all referral. Now, as the indication increase, it has come. I'm sure now with this encouragement, I think even many people will start to look at this. Hope it was very informative session, and Sandeep, I think you have done a wonderful job. I think I really liked your video at the end, because so practically, I think all what you told in theory in that 10 minutes video, I think it was really well covered. I think you looked into the minute details, even how to place and how to mark the points, and I think wonderful presentation. Hope we will get a chance to listen from him more with newer indications and better, more convincing with data. Thank you, Sandeep.
Sure.
We will end this session here. Thank you.
Thank you. So whoever requires this one, I'll send the compressed one. This is more of MBL and video ikkade pettesanu that I can't compress certify.
Thank you, sir, for your valuable inputs. I request Dr. Keshavrao, sir, to present mementos to the chairperson and the speaker. Thank you, sir. So let's break for lunch, and we'll meet again in the same hall at 2 o'clock. Before leaving, I request the postgraduates to confirm their participation to Akhila, ma'am. మీ దగ్గర ఈ ప్రెజెంటేషన్స్ ఉన్నాయా మీ దగ్గర?